project on how well doctors are prepared in terms of the finance education for consultant roles and senior management roles. So there's a pre-teaching survey and there's a post-teaching survey, which we'll send you links to. So if you could be really useful for us to see if we can tailor things specifically. And we'll do another one in probably next year aimed at the wider non-finance staff, so non-clinicians. But this is specifically at this moment based on his dissertation project for clinicians, for medical doctors. But we'll do one in the future, tailoring a bit more. So a lot of what we're going to be saying and more information is available on our one of our websites, financeforclinicians.co.uk. It links to the One NHS Finance website, but it goes directly to one of our pages with our resources on. As I was saying, the purpose of today is to help you navigate the health system. It's not to make you accountants. It's not to make you, penny pinchers or anything like that. It's just to help you understand how the system works, help you navigate it, and help us deliver the best possible care we can for our patients within the finite financial framework that we have. So again, the main purpose, and we will always be, and we will always want you to be, clinically driven, but it's just about being financially aware of the cost implications within the finite environment, so that if we can save money in one area, we can spend it in another. And that's the ultimate aim. So what that essentially means is that we are trying to demonstrate value in healthcare. And there are three types of value in healthcare, and three different definitions. The first one is something called allocative value, and that's related to how well or how the resources that we have are divided up. So it can be at national level, it can be at system level, but it's all about how you allocate the resources. It's also called economic value. What we at the kind of more acute, not acute end, but at the front-facing side of things tend to focus on is technical value. And that's how you make best use of the resources that you have. So you've been allocated a certain amount of resource, and it's how you make best use of that. And that's called technical value. And that's what we're going to be talking about in a bit more detail in a second. It's also called efficient value. And the final thing is something called personalized value. And that's related to the fact that you, me, our patients, they all have different values. They have different things that they value. And it's something that we need to be aware of. An example, so Virginia Mason is a system in America that's very big on value-based healthcare. And they did some work with one of the systems in Wales. And as part of that, they did some studies looking at a neurology clinic. And they asked the clinicians what they were aiming to get out of a consultation. And they asked the patients what they were wanting to get out of consultation. The clinicians were very much focused, rightly so, on the diagnosis and on the treatment of said condition. Whilst the patients, their priority was generally, and this is, it was generally things like better sleep, more energy, being able to function. And whilst those things overlap in many ways, there are sometimes it doesn't overlap. And it's just understanding that different people have different values. And that's called effective value. So we're going to briefly make this into equation, because this is the value side. And what I want people to try and either shout out or put into the chat, and I'll just log into the chat a second, is what you think is in the top line and what you think in the bottom line. So we want one word for the top line and one word for the bottom line. See if I can find the chat. I have to stop sharing for a second to try and see the chat. So one word for the top line, one for the bottom line. Oh, somebody's got this straight away, quality and cost. Okay, so we're going to have quality and cost, and there are three bits to quality. What do people think the three components of quality are? It's in the NHS constitution. It's in the legislation. The three domains of quality. So there's lots of different definitions of quality around the world, but there's one specific thing that is used in the NHS, first proposed by Darcy. So three domains of quality. So clinical outcomes, yep. Yep, clinical outcomes. Patient-centered. Effectiveness. Okay, that kind of sits with outcomes. Any others? Patient satisfaction. Okay, yep. And somebody's put it at the near the top. Safe. Yeah, so patient safety. So got quality over cost. So cost is clinical outcomes. Now, it's important to note that clinical outcomes, there's no specific measure of clinical outcomes, and it's when you're looking at this for your business cases or for your evaluations or whatever context you want to look at value, there isn't a specific clinical outcomes that you need to measure. So it can be length of stay, it can be mortality, it can be complications, it can be a variety of things, and there's no specific time limit. And the reason I say that is there are interventions that we can do that may not have a benefit in the immediate period, but may have a longer term benefit. And traditionally, that's been harder to justify or quantify because of the nature of our annual cycles or 3-year cycles. And an example of this is, so as an anaesthetist, a lot of my examples may be surgical or acute based. Now, I am trying to think of more community and mental health based examples for those of you from other places. But one of my surgical colleagues have a different way of closing an abdomen after doing a big operation, big laparotomy, and it takes a bit longer. It takes about half an hour longer to close the abdomen this particular way. And so that can be deemed inefficient because it doesn't impact the patient's length of stay. It doesn't impact the 28-day or 30-day mortality. It doesn't impact outcomes in a year. What it does do is reduce the longer term complications of incisional hernia. So hernias happening at where that incision was. And that has a big impact on those operations are quite complex and quite big operations. So it has a big impact on the longer term outcomes. But if you just used the standard outcomes that we would normally measure, 28-day mortality, 28-day complications, readmissions, 30-day mortality, length of stay, it wouldn't show up as an improvement and may be considered bad, not good for value. So it's tailoring the clinical outcomes to what you're trying to look at. So patient experience is important, and patient safety. And then costs are generally divided into two components. You have your revenue costs, which are your day-to-day running costs, and your capital costs, which are your big upfront expenditures. Now, increasingly, we're looking at environmental costs and societal costs, but they don't factor in directly into this equation that was created by Michael Porter, who's a Harvard business professor. But the purpose of this is basically to suggest, and he had there's two real outcomes for this. As if you are trying to put forward a project, you have to show that the improvement in quality in one or multiple domains is worth the revenue or worth the costs of implementing it. That's the first thing. The second thing he also said was that generally, if you improve quality, you will reduce costs. The problem is that costs may not necessarily be to your department. It may not necessarily be to your hospital. It may be to the wider system. It may be societal benefit. Okay, so we have to think a bit wider than the specific costs that we look at. And that's where it becomes a bit more difficult when we're trying to justify, business cases and things like that, is that those benefits are harder to quantify. Now, increasingly, as there's a shift to appreciate environmental and societal costs, that is being considered and factored in. But at least traditionally in the past, it's been harder to look at those points. Okay, so that's the first part of just the introduction of why we're doing what we're doing. So the next bit is for me to talk about NHS structure, a bit about how money flows through the system, and payment systems. So, so the NHS structure has kind of continuously changed over the last 60, 70 years, since its conception in 1948. So in 1962, there is the hospital plan, which was Enoch Powell's, who the health secretary at the time, idea that there should be a district general hospital for every 250,000 or 125,000 of the cap of population, because hospitals before then weren't really planned; they would just happen to be in urban areas. And the NHS wasn't really a planned system as such. It was a nationalised system. So they started that, but they ran out of money. And then there have been various other iterations. There was in the health authorities came about in 1974, the development of the internal market in 1990. You had the NHS plan in 2000. You had the Health and Social Care Act 2012, otherwise known as the Lansley reforms, which are the kind of biggest reforms that have happened recently. And then most recently, last year, we had a bit of a tidy up with the Health and Care Act. Now, it is important to note that the Health and Care Act was more of a tidy up of the legislation rather than anything dramatically different. Since the Lansley reforms came in, which is a big thing, they did lots of changes. They have the NHS for 10 years since then have been trying to kind of manoeuvre to shift away from internal market more towards collaborative healthcare within the kind of legal framework. And the Health and Care Act has basically tidied up that legal framework. Is essentially what's happened. But I will talk a bit more about the legislation in a bit. So the budget is set by Parliament, and hopefully there is a animation in a second. No, okay, in a second. Okay, I'll go through the budgets in a second. Yes, you will get a copy of the slides. All the slides will be sent out shortly. So the Department of Health and Social Care is the department that's responsible for health in England, and it's very important to say that a lot of the stuff we're talking about today is related to England. Health is a devolved entity, a devolved function, and so it is the devolved nations are responsible for their own healthcare. And when we talk about funding, we're talking about funding for England. But there are some bodies that have national, UK-wide responsibilities. And again, whilst it's called the Department of Health and social care is funded via the local authorities and not by Department of Health budgets. Okay, there are 12, I think currently 12 arm's length bodies or bodies within the Department of Health and Social Care. How many can you name? So again, in the chat or in the or you can shout out, how many of these can you name? Again, I'm going to briefly stop sharing while people come up with any. And this is as much to stop you having to listen to me all day than it is to do anything else. Can you name so I'll give you one, NHS England. Okay, so that's one of them. NHS blood and transplant, yes. Any others? HEE, you would have been right about a few months ago, but HEE no longer exists. Health Education England has been dissolved and absorbed into NHS England, as has NHS Digital. That went last year, where it became part of NHS England. I don't know what OHID is, but NICE, yes, is one. The National Institute of Clinical Care and Excellence. The UK Health Security Agency is another one, yes. So NHS Digital no longer exists as a separate entity. It was absorbed into NHS England not that long ago. So interesting. We're going to talk about supply chain when I talk about the procurement. You've got me for procurement today as well. And it's no, so supply chain is a slightly, it's actually a private company that's owned by the NHS rather than funded by the NHS. And we'll talk about how that works in a bit. CQC, yes. Office of Health Improvement and Disparities. Yeah, so I think that's now part of the UK Health Security Agency. So you've got your Medicines and Healthcare Products Regulatory Agency. You've got your UK Health Security Agency, which used to be called Public Health England, but has a slightly wider remit now. And I think the Office of Health Improvement and Disparities sits within that or within NHS England, but it's certainly not a separate body. You have NHS Blood and Transplant. You have the Business Services Authority that looks after prescription charges and pensions and various other financial things. NHS Resolution is the new, well, not so new name for the Litigation Authority that looks after patient safety and deals with the indemnity system. And you've got the NHS Counter Fraud Authority. Now, they're officially classed as executive agencies, special health authorities, and arm's length bodies, or executive non-pump, but they're essentially all funded by the Department of Health and Social Care. They just have different, the Department of Health and Social Care has different levels of control over them, essentially, with these bodies. So the commissioners at NHS England, and they are now the only commissioners of nationally. And you have National Institute of Health and Care Excellence. So health education no longer exists. NHS Digital no longer exists. And you have lots of regulators. You have the Care Quality Commission. You have the Human Fertilisation and Embryology Authority. You have the Human Tissue Authority. You have the Health Research Authority. And then the new body is the Health Services Safety Investigation Body. So that was set up earlier this year officially. So it's been in existence for a while, but it's now has its statutory standing as a separate body now. So it's important to note that when governments, and multiple governments, have suggested that the health budget in England is protected, the budget that tends to be protected is NHS England's budget. And that has meant that a lot of the other bodies have had to have massive funding cuts. So CQC and all the regulators, Health Education England had a massive funding cut a few years ago in order to protect and fund the kind of core services, NHS England services. So whilst they often say NHS England or the healthcare budget has been protected, it's not the Department of Health and Social Care's budget that's protected. It's NHS England's budget that's protected. So just to be aware that a lot of the other agencies have had several significant cuts. Okay, so I'm going to go back a little bit to look at the funding now. Now that I put it into context, you can see that of overall the funding for the last few years and for next year is slowly going up. The capital budgets have gone up a little bit. The Department of Health budgets are not really going up very much, but NHS England's budgets are going up a little bit. Okay, so I kind of I switched the order of the slides in order to give you some context as to what that means. It means that the Department of Health and Social Care, excluding NHS England, from between this year 23-24 and 24-25, is actually getting a pay cut, or a funding cut, because NHS England improvements budgets are growing. These are billions. These are these are in billions of pounds. So the current funding of the Department of Health and Social Care is about 180 billion pounds, ballpark. Okay. I'm hopefully I'm going to see if this works. Once I've shared sound, sometimes my speaker things don't work. So please let me know if you can hear this.
This animation gives an overview of the structure of the NHS in England and describes how the money flows. How public money is spent is determined by Parliament, and more specifically, the Chancellor of the Exchequer. Money allocated to healthcare is determined by the Spending Review, which is usually every 3 years, and amended annually by the Budget Report. The government department responsible for healthcare is the Department of Health and Social Care, which has the largest amount of pre-allocated public money, with an annual budget for 2023-24 of £188 billion. This is divided into £176 billion of revenue funding to cover day-to-day running costs, such as staff salaries and medicines, and £12 billion of capital funding to pay for infrastructure and maintenance costs. Health is a devolved function, so this funding is only for healthcare in England, as social care is funded separately via local authorities. From the budget, the Department of Health and Social Care has to pay its internal costs and fund several executive agencies, special health authorities and arm's-length bodies. The biggest of which is NHS England, which legally merged with NHS Improvement on the 1st of July 2022 as part of the Health and Care Bill. NHS England has now also merged with NHS Digital and Health Education England. NHS England received the majority of the Department of Health budget, with funding for 2023-24 of £160 billion. NHS England works via 7 regional teams to support the delivery of the NHS long-term plan. The plan was published in 2019 and outlines the key ambitions for the health service for the next 10 years. To create a service fit for the future and get the most value for patients out of every taxpayer pound. The Health and Care Bill builds on the long-term plan to support integration. NHS England has a budget of £27 billion for directly commissioning services, including some primary care services and public health. It directly commissions military healthcare, health services in the justice system for healthcare for children, young people and adults across secure and detained settings, and specialised services. There are 154 directly commissioned specialised services, which are grouped into 6 programmes of care: internal medicine, cancer care, the trauma programme, women and children, blood and infection services, and mental health. Over the next few years, NHS England will delegate some of its commissioning responsibilities to local commissioners, with pharmacy, ophthalmology and dentistry services fully delegated by 2023. 9 regional committees are being created to commission specialised services from April 2023. They are joint committees between NHS England and the relevant integrated care systems in each region. Following several years of locally led development, 42 integrated care systems, ICSs, were established on a statutory basis on the 1st of July 2022 as part of the Health and Care Bill. Integrated care systems have 4 main purposes. They bring partner organisations together to improve outcomes in population health and healthcare, tackle inequalities in outcomes, experience and access, enhance productivity and value for money, help the NHS support broader social and economic development. The new ICS are led by an Integrated Care Board, ICB, and an Integrated Care Partnership, ICP. The exact composition of both the ICB and ICP will vary between areas, but as a minimum, the Integrated Care Board will include a chair, the CEO, and representatives from NHS providers, general practice, and local authorities. ICBs replaced clinical commissioning groups, CCGs, and are now responsible for developing a plan for meeting the population's health needs, managing the NHS budget, and arranging for the provision of health services in the integrated care system. The majority of NHS England's budget, £107.8 billion, is allocated to ICBs for commissioning local health services. ICBs plan and commission services for their patients. The Integrated Care Partnership will also include the ICB CEO, local authority representatives and NHS providers, but may also include representation from other organisations. The Health and Care Act has seen a shift to more strategic commissioning and a more collaborative approach to planning care. Allocations are made from NHS England to ICBs as the system funding envelope. ICBs will have the flexibility to manage resources within this envelope to deliver agreed local priorities. ICBs will agree on contracts with providers, with increases expected to be based on aligned payments and incentive basis. Organisations within ICSs have to adopt and adhere to a shared control total, which in effect binds them to meeting a collective target for financial performance. So, in summary, money flows from Parliament via the Department of Health to NHS England, and in the most part, integrated care boards to the organisations that provide patient care.
Great. So it is a lot of information. We will send you the link. I'll try and put it in the chat after my talk, and we'll send you it with the slides so you can watch it back in your own pace, because it is a little information. It is up to date. It was released a couple of months ago, so it's about the latest information that we can get about all the money and structures, but it is constantly changing. So going back to the Health and Care Act and some of the changes that have come about from it, it's based on a white paper that was released in early February 2021, which in itself was based on something that the NHS England put to the government to say, these are the changes we want, these are the things we're struggling with. Obviously, the government tweaks it a little bit, and it went through Parliament and became effective in July last year. There are lots of components to it, but we're only going to be talking about things that affect the structure of the NHS rather than a lot of the kind of other bits and pieces. I think there's 130 different parts to it. So the first thing was to make the statutory care boards and integrated health and care partnerships statutory bodies. So before the ICS, we had was a joint, thing that whilst every organisation was a part of, it didn't have any statutory footing. It didn't have any legal footing. So that they're now replaced CCGs, the clinical commissioning groups. The Health and Care Act 2012 made it obligatory, mandated competition. It made different organisations compete for work. It made it a obligation that the commissioners had to put out for tender any healthcare services that they were looking to do, unless there was a particularly good reason. And essentially the system, or the government, NHS England, have found that didn't work, and so there was a duty to collaborate. So whilst there were joint committees and people were in joint roles, it was all a bit uneasy, and it wasn't official. So now there is the ability to have joint appointments and joint committees across organisations, across ICBs, and there is a degree of encouragement. Well, there's actually a duty to collaborate, so that all organisations are mandated that they have to collaborate, and that the requirement for competition has been removed. So the commissioners are allowed to put things out for tender, but they are not obliged to. So if there isn't or if they feel that it's in the benefit of the system to put a service or proposed service out to tender, they will, but they don't have to. That's probably the key thing. It's all about integrated care to a greater degree. The other thing that it was tidy up the legal framework. So NHS England is the commissioning body, and then the regulators, or the overall regulators of NHS organisations, were still officially two different bodies. There was a Trust Development Authority, which was set up to try and help NHS trusts become foundation trusts, and then there was Monitor that looked after the foundation trusts. And quite early on, they realised that wasn't feasible, and so they merged to form NHS Improvement, which were the regulator. And then we had this situation where the commissioners were saying one thing and the regulators, NHS Improvement, were saying something different and sending mixed messages. And so they decided to merge. And for a while, it was called NHS England and NHS Improvement, but now it's one body called NHS England. So healthcare is commissioned and regulated by NHS England. There is also some changes in terms of accountability. When NHS England was first formed, it was very much an arm's length body, which essentially the department, the Secretary of State for Health, set a mandate to every year, but now they've changed to give the Secretary of State for Health and Social Care increased powers to have better oversight over NHS England. So just to briefly cover, just looking at the questions, ICB and ICP, I think it will be covered in a bit more detail in the commissioning section, but broadly speaking, the ICB is the replacement for the clinical commissioning groups. They are responsible for the commissioning of services within the integrated care system. And they comprise the chair, CEO, and then representatives from the NHS providers, so the acute, the mental health, the community, the ambulance, primary care representatives, and local authority representatives. And they are the people that look after the kind of NHS healthcare services. The ICP is a wider collaborative that may include that have the same some of the members of the ICB on there. So they have representatives from all those healthcare bodies, but will also have, in addition to local authorities, they may have the police, they may have housing associations, they may have charities and third sector to try and bring in that integration between health and social care. And that's the key point to it. As I said, I'm hoping it might be covered in a bit more detail in a bit. Okay. So going into payment systems, and I've got 10 minutes, good. So payment systems in the NHS are changing continuously. We've had a variety, and even in the last 5 years, we've had a variety of different payment systems. And no one payment system seems to be ideal. And so what I thought we'd do is just go through the different ways that services can be paid for. And this is not just in this country, but this is internationally. Internationally, there are certain building blocks that are put together to form a payment system. And so internationally, these are the different ways that a provider organization can be paid for the services they provide. And it works differently in different places. So the first one is a block contract, which is a lump sum payment to cover a specific range of services. A true block contract, it doesn't matter. You set, you predict how much activity it's going to cover, but once you set the amount of money, you don't change it based on how much is demanded or how much is required. Okay, and it's traditionally used historically for things that are hard to measure. So when you can't measure things very accurately, you tend to go to a block contract because it's predictable. The commissioners know how much you're spending. The provider organisations know how much they're receiving. Okay. The problem is that if, for example, the provider organisation over delivers, so we thought it was going to deliver 100 hip replacements, but did 120, doesn't get any more money. And if it only delivers 80, doesn't lose any money, which then means the commissioners are out of pocket, as they paid a higher rate for each hip replacement. So it's good because it's predictable. It's bad because it doesn't vary between demand and supply. That's why it's used for things that are hard to measure, or in times of crisis. So we've had block contracts over the last few years during the COVID pandemic because things were hard to measure and were going to be very variable. Capitation is how lots of it's how the integrated care systems get paid. It's how the regional health boards in Scotland and Northern Ireland get funded, and it's basically a payment based on the size and complexity of your population, so by the provider. The formulas used to work out or to weight that population vary. So it's a particular formula for GP services that factors in the age, the social demographics, the needs of a population, and means that the amount of money is weighted accordingly, and the population is adjusted. But in different areas and in different situations, the weighting equation varies, and that's where the controversy comes in: is how things should be weighted. But capitation is a key method of funding things like ICSs and health boards. And then you've got pathway of care. It goes in and out of vogue, pathways of care. So the idea being that you get a whole pathway that's funded, and the benefit is that you can get a lead provider that they can then subcontract out parts of the pathway out. So it has been used in maternity services. It was thought they were planning on using it in things like hip replacement. So from referral for a hip replacement to rehab and everything else, that was going to be a pathway of care, and there was going to be a lead provider that then subcontracts out the different elements of the pathway, and they got payments for that. But it has been used in hospital and maternity services, but again, we've moved away from it now. In maternity services, you've got a payment for antenatal, a payment for intrapartum, and a payment for postnatal care. And the problem is that whilst there were different levels, so you had 3 levels for antenatal, so low risk, medium risk, high risk. You had 5 levels for intrapartum, so the kind of delivery, and I think 3 or 4 levels for postnatal. Once you were started on the bit of the pathway, so if you were deemed a low risk pregnancy, you got the low risk pregnancy payment for your antenatal care, and you wouldn't get any more money even if you became a high risk pregnancy during that period, and it required lots more scans. So it often meant that providers providing the different bits of the pathway were losing money, which is one of the reasons it went out of vogue recently. Pay for performance is part of every contract. So in the acute in GP world, it's the QOF, the quality for outcomes framework, which can equate to 20% of your income is by meeting the QOF targets. Whereas for the acute community mental health services, the sequins, when they were first came out, they were 2.5% of the contract value. Now they are more 1.25% of the contract value. And you get national and you get local sequins. But there's always an element of pay performance. Something that's not used in this country very much is the lump sum payment per patient per day of care, based on the level of care. So a level 0 patient would get X amount per patient per day of care. A level 1 patient, a level 2 patient, a level 3 patient would get X amount of money per patient per day of care. It has been used to look at excess bed days in the acute sector when we were doing payment by the national tariff case-based activity, but it doesn't get used very much in this country, but it is used in lots of other parts of the world. And then case-based is probably the most famous. It's been called payment by results, it's been called national tariff, but essentially the more work you do, the more money you get. And it all depends on the complexity of the diagnosis, the treatments that are given, and the patient characteristics, the comorbidities. And you put them into a computer software, and they give you out an HRG, which is a healthcare resource group, which basically are groups of things that consume a similar amount of healthcare resource. And the tariff, the national tariff, is allocated per HRG. It's good. It's the thing that's used probably the most frequently in most parts of the world now, and it's being used in this country traditionally for everything in acute and mental health, but more now it's being used for elective care, and it's very good for elective care because obviously the more elective care you do, the more money you get. The problem for emergency care, and why it doesn't work for emergency care, is the tariff is often not enough to cover the cost of delivering that emergency care. And then finally, you get pass-through payments where the cost of the service is paid for directly by the commissioning body. So whatever it costs you to deliver that service, you get reimbursed fully by the commissioning body. So an example of that is the high-cost chemotherapy drugs. Right. To address the question that somebody's put in about PBR, the current contract that's in force for almost all aspects of healthcare in England is this aligned payment incentive contract, and it essentially has 3 components. It has a fixed element, which is covers the bulk of your costs. So it's the works up to an agreed level of activity. Okay, it covers maternity, mental health, community, and ambulance services. This fixed element. It includes the expected, so the BPT is your best practice tariff. So the best practice tariff is you basically get slightly more money in the tariff if you achieve certain criteria. So there's a neck of femur or femoral fragility fracture best practice tariff that means that if you get early surgery, review by geriatricians, early physio, early discharge planning, and all that kind of stuff, if you achieve all of that in 80% of your cases, then you get the higher rate of tariff. So you kind of put that into your baseline, your expected amount, your expected sequin achievement, your clinical negligence scheme for trusts contributions. So that's your indemnity contributions, and anything else that's in your fixed element gets put in there. And that's your kind of baseline. That should cover the majority of your costs. Okay. And then you have your variable element, and that's basically for electives. So the more elective activity you do, the more money you get. So that's your elective ordinary and day case, any outpatient procedures with an NHS payment system. So NHS-PS is the NHS payment system unit price. So there's a big document that has, it's called the NHS payment system document, and it basically has a unit price for each, for different procedures and for different HRGs. You get a variable element for outpatient first attenders, but not for follow-ups, for diagnostic imaging, nuclear medicine, chemotherapy delivery. So that's your variable elements. That changes based on the activity. And then you get an extra top-up, which is basically money taken away if you don't achieve your best practice tariff or sequin. Okay, and so that applies to all the tariffs apart from the low volume activity contracts, which are the ones for less than £500,000, which tend to be for cross-border, cross-ICB, cross-ICS, cross-ICS activity. So, if you have people that go to across the border or are on holiday makers and things like that, they have, you'll probably find that there's a high proportion of, there's probably a contract between London and Cornwall for low volume activity, because in the summer months, quite a few Londoners go across to Cornwall. Oh, the dog in the background. So that's basically a very, very quick overview of how the NHS system works and the structure and the funding works. Are there any questions? Feel free to ask me anything at the moment, or you can email me. The easiest email to remember, my email's my first name dot second name at nhs.net or at UHL, or if you can't remember that, it's ak@clinical.finance. Any of those emails will get to me. That stunned silence. I said it is very much a whistle stop tour rather than trying to be comprehensive. Can
I ask a quick question?
Yep.
It may be more relevant to later when you're focused on specialist areas, but if a particular ICB cannot offer a particular service, what's the structure? Because you talked about the kind of funding that goes across different, like say somebody wants to be treated for ingrown toenails and the local ICB can't offer that. How do they fund it to happen in another area? What's that process called?
I assume that'd be part of the commissioning of how it gets, so if you can't offer a particular service, you'd have to commission another service to deliver that care, and depends on, that tends to be specialized commissioning. So the ICB will, traditionally it was NHS England that did it. Now increasingly it's going to be the ICBs that do it in the future. and they will have a system where they will contract out their specialised service to a particular area. When they do the specialised commissioning delegation, there will be some specialised services that are deemed super specialised, and so NHS England will still do it to make sure there's parity in ensuring that it's you don't have to travel too far to receive that specialised service, essentially. But with the specialised services, it is very much a so ECMO, which is a kind of extracorporeal membrane oxygen, and there are 5 or 6 centres around the country. Where you send it will be determined by NHS England increasingly rather than the ICBs, whereas something that's a little bit more common, renal dialysis, which is still an NHS a specialised service, will probably be delivered at ICB level. And so if, for example, a particular ICB can't deliver it and they want to commission the next door ICB to do it, or the provider to do it within the other night, that's how they do a contract.
Okay, thanks.
But I'm hoping somebody else, our next speaker, will be able to elaborate a little bit more. So I'd like to welcome Eliza Lewin, who's Director of Contracting and Commissioning, Contracting and Costing at East Kent Hospitals University NHS Foundation Trust, who's going to talk about commissioning in the NHS. Over to you. Thank you very much.
Thank you, Akabine. Good morning, everybody. As I've been introduced, my name is Elisa Llewellyn and I work for East Kent Hospitals. With regards to commissioning, an ICB will typically, obviously, it commissions its services via contracts with various organisations. So if there are no organisations in a particular patch who provide those services, they will typically approach other providers out, as near as possible to the patch. But obviously what you want to avoid is patients having to travel too far for their services. And it obviously depends, as the previous presenter mentioned, on the level of complexity of the service as well, and how many available providers there are. But it's all effectively then commissioned via the NHS standard contract with whichever organisation then provides it. Okay, so I'm going to share my screen. I apologise, there may be some overlap with the previous presentation. Okay. Hopefully, now obviously because I've started slideshow, I'm not able to see anybody. Can I just confirm, could somebody confirm that they can see my slides?
Yeah, you're all good.
Yeah, thank you. Okay, so the content this morning is essentially what's commissioning, how we travelling on the journey to integration and working with other healthcare and local authority partners. What is the NHS long-term plan and annual planning priorities? A little bit on how the money flows, although that is probably a bit of a repetition from previously. How is commissioning changing? And then the regulation and monitoring that all organisations are subject to. So commissioning is a continual process of planning, agreeing and monitoring services. It's really multifaceted. It's about understanding the health needs of the local population within the particular geography that you're commissioning for, and basically designing patient pathways in order to meet patient needs as best as possible. Commissioners are responsible for setting service specifications up, for being very clear about what they're expecting providers in their patch to be able to deliver for very specific services. And there's an element then of negotiating with providers basically on what level is achievable and what journey will you take in order to ensure that you are meeting all the requirements, national and local requirements of the contract. So essentially, most organisations within the NHS will be commissioned by the Integrated Care Boards, or ICBs, and they are overseen by NHS England. So as we know, NHS England's specialised services and public health arms and health and justice, they also are responsible for commissioning screening programmes, more specialised services. But what we'll see over the next year or 2 years is a movement from NHS England specialised services to ICBs for the commissioning of the majority of their services. So things like renal dialysis, some cancers, specialised rheumatology, they're all going to move to the ICBs. Some things have already moved, so you may have noticed that the secondary dental contract that used to be commissioned by NHS England, that was moved to the ICBs from July of last year. And optometry was another one that moved over. So that's going to be a gradual movement, and that will mean really, and the whole aim and the impact it's going to make is that it just gives ICBs greater control over a range of services, and really it's looking at how can we ensure that those services are centralised in the best possible place, so that we've got enough of a population in order to offer greater specialised care, but also in order to have economies of scale, really, ensuring that that resources are in the best place, and therefore you haven't got too many management structures with multiple provider organisations. So ICBs obviously sit within an integrated care system. Now, these are partnerships and organisations that come together to plan and deliver healthcare services. And essentially within England, there are 42 ICSs at the moment. So this schematic here just shows the structure of the integrated care system. So NHS England performance manages the NHS and all of the organisations within the ICSs, and then obviously the Care Quality Commission does the quality reviews. So the Integrated Care Board, essentially, it's got an independent chair and then non-executive directors, and then they'll have members from nominations made by NHS trusts and foundation trusts, local authorities, general practice, and basically an individual with expertise and knowledge of mental illness, which is a key objective, is to ensure that the aspirations of the mental health paper are being achieved. And the role of the Integrated Care Board is this is the board that essentially puts the structure in place in order to deliver all of the key planning assumptions that providers are expected to achieve. So they will hold the budget. So they will be given a budget on an annual basis. I think for this year we had a 2-year budget that was allocated. And along with that budget that's allocated to the ICS, there will be a range of expectations for how that money is spent. So they're essentially buying healthcare, but more increasingly actually working more with the Integrated Care Partnership. Now, the Integrated Care Partnership is representatives from local authorities, ICB, Health Watch and other partners, and the idea is to meet the wider health and public health and social care needs, and by these have cross-body members so that they gain influence and align each other's aspirations and goals, and then essentially then within the system, you will have these sort of really graded by size. So you'll have provider collaboratives. So this is really where you've got 1 to 2 million people, and it's all your major providers and sometimes voluntary community social enterprise organizations, and also the independent sector organization. And the point of this is to essentially start to look at, collaborating, putting care in the right place, and really working together to make that patient pathway more seamless. So then we've got these place-based partnerships. And this is for a population, so it's basically a more intense look at the local population. So it covers about 250 to 500,000 population. And within there, you've got place-based partnerships again. So it's the usual organisations, but from more locally situated. Will be commissioned to do that integration work there. And then we've got these sort of primary care networks in this neighbourhood, which is a much more localised group that includes general practice, community pharmacy, dentistry, opticians, that kind of thing. And they are looking at how they can work together in order to improve the health and well-being of the population. So this is, I won't go through this because I'll probably run out of time, but the slides will be shared, so there's just a bit of extra information there. And then obviously the purpose of this is to bring partner organisations together. We want to improve outcomes in population health and healthcare, tackle health inequalities, which is, really came to the fore, didn't it, during COVID, when, it became obvious that those who struggle to access healthcare services were really disadvantaged. And there is specific money that is given to commissioners in order to ensure that health inequalities are tackled, and that is a key area that needs to be focused on. And in fact, you may have noticed in your organisation now, if you write a business case, you have to then state, whether that case has an impact on health inequalities within your organisation and your local population. So enhancing productivity and value for money is another key one, and that's really working together. So within an ICS, we will look to harmonise maybe back office functions, harmonise some IT and computer systems so that, so that we actually start to work together better, and we're able to operate in an integrated way, and we can speak to each other, not just face to face, but digitally as well. So care organisations obviously have lots of complex challenges. These are some of the aspirations, that really need to be tackled, those people with multiple needs, multiple health needs, and improving the health of children and young people. So I guess the question would be well, how do we know what to focus on? I mean, there's so much to do, isn't there? I mean, if you started a list, it would be a very, very long list. So the framework that we all work to in deciding our priorities is the NHS long-term plan. The sort of high-level plan aspirations, ambitions, are improving patient options, to obviously support properly joined up care in the right time, in the right place. Now, this plan was put together in consultation with a lot of different organisations, so that would have been, including people, in the population. So it's really did, do a lot of consultation with lots and lots of different patient groups. So this was very, very clear, that the joined up care agenda is something that we all really need to be focusing on. So then they're funding evidence-based prevention programs, so cutting smoking, reducing obesity, lowering air pollution. And again, you may also have noticed in your organisations, if you're writing a business case, you know, whether or not it has an impact on the green agenda. Again, tackling health inequalities, and then it's essentially focusing on cancer, mental health, diabetes, multimorbidity, and healthy aging, including dementia, amongst others, were the key priorities. Also looking after staff. We know that recruitment and retention is an issue within the NHS. So actually looking at supporting staff, so increased education and training places, improving flexible working, and hopefully all your organisations you work for are offering now much better flexible working options, and you know, ensuring that staff have the professional development that they need. Then the digital, so it's electronic patient records across organisations and care plans and those sorts of things, all of these things that will support this joined up care that we're talking at the top. And then there was a commitment to fund 3.4% over 5 years. Over the last, apart from COVID, but pre-COVID, it was only 2%. So there has been a significant increase in funding compared to pre-COVID levels. So that's the long-term plan. And then every year the NHSE will publish its priorities and operational planning guidance. So for 23-24, hopefully you've all been involved with it in your respective areas. So all organisations will have been putting their business plans together, and they were submitted in May of this year. And so essentially there were sort of three immediate priorities, and that's to recover core services and productivity, make progress in delivering the long-term plan ambitions, and then continue transforming the NHS for the future. So this is quite a busy slide I've got here. But these are the national objectives that commissioners, the ICB, will be expecting the organisations it commissions to achieve, and the ICB themselves will be responsible for oversight and ensuring that the providers in their patch will be able to deliver these. So obviously there's various areas of urgent and emergency care. There's an expectation that no less than 76% of patients are seen within 4 hours by March 2024. Ambulance response times, which has been a real issue, so it's essentially improving the average of 30 minutes in order to get back to pre-pandemic levels. Community health services need to meet or exceed the 70% 2-hour urgent community response standard, and reduce unnecessary GP appointments, improve patient experience. Primary care has 4 specific measures that it's being asked to tackle, the main one being to make it easier for people to contact a GP. And then this trajectory to deliver 50 million more appointments in general practice by the end of March. So the ICB will have to, you know, work hard to ensure that that can be achieved. Elective care, as you know, eliminate waits of over 65 weeks for elective care by March 2024. And cancer, need to reduce the number of patients waiting 62 days. And I'm sure you know all of this, but you know that it's a very, very sizable list of objectives that the ICB needs to keep oversight on. And mental health is, as I said, is a particular focus, with lots of investments coming in for mental health services over the next few years. So we've got to do all of those things. So commissioners have to do all of those things. So how is it funded? I know this was covered previously, but just very quickly. So the Department of Health and Social Care gives all the money to NHS England, who then divvy it out to specialised commissioning, integrated care boards, primary care. And these ICBs will look after acute mental health, community, ambulance. They will also, and these are the services that are part of the NHS payment scheme, as in the tariff systems. I don't think we need to do that. So the tariff systems will cover outpatients, maternity services, A&E, elective, non-elective, community, mental health, ambulance and other. Outside of the scope of the payment system then is primary care, high cost drugs, social care, public health, training, admin and capital. So these are the different payment mechanisms. So the aligned payment and incentive, which is what the majority of organisations will be, provider organisations will be on. Essentially, I mean, a lot of the aligned payment and incentive contracts that we're on, actually, a lot of it is fixed. So there's only some variable elements, and the main variable element, apart from high cost drugs and devices, is elective day cases and outpatient first appointments and outpatient procedures. So they are variable, so they will be costed up at the national tariff, and they will be paid on a variable basis. There's also funding that is received, so commissioners out of area with small contracts under £500,000 are now low value activity contracts. You don't have a contract with them. Trusts will just be paid a block payment every year for every ICB that they do a small amount of work with. So just quickly moving on to regulation. So now the ICBs and providers are subject to the National Oversight Framework. So essentially ICBs have a general statutory function of arranging health services and will be responsible for performance and oversight. So NHS England undertake an annual performance assessment of ICBs. So commissioners themselves are subject to an annual assessment, and they assess commissioners based on these 6 key areas. So quality of care, access and outcomes, preventing ill health, reducing inequalities, finance and use and resources, people, leadership and capabilities, local strategic priorities. So every year they will have to write a report that says, you know, this is how we're doing on all of these key metrics. So what happens is, depending on how your performance is being measured, you will be put into one of 4 levels of oversight. And essentially, if you're in level 1 or level 2, so they call it SOF 1 or SOF 2, or you might have heard NOF 1 or NOF 2, we'll have changing a name. Essentially what you'll see is that you're allowed to be very autonomous, you're succeeding, you're consistently performing well across all of the key areas that you're being measured on, and you don't really need any specific onerous or targeted support. But then if you're in 3, so SOF 3, then what's happening here is that your organisation is really struggling against one or more of the 6 oversight themes, and there'll be gaps in your ability to deliver the statutory and wider responsibilities of that particular service that's in trouble. So essentially, if you're in there, then what will happen is, you'll be sort of given mandated support, and there'll be a regional improvement hub that you can sort of tap into and access national expertise. And then the SOF 4, which is obviously the lowest tier, it's the one that nobody really wants to go to. Now, that has very, very serious implications for the organisation. So essentially, you've got complex issues, which it doesn't look like, that the ICB or providers are able to get themselves out of without any support. So what happens here is these organisations will go into the recovery support programme, and once you're in there, it will then severely limit your ability to make independent, autonomous decisions, either as an ICB or as a provider. So I think that there's sort of double lock, triple locks in progress for service developments, those sorts of things, so that, especially with financial recovery, trusts and organisations will lose their ability to plan their way out of an issue without it being signed off by the regulators. So I shall leave it there. Any questions? Or have I sent you all to sleep? Jacqueline.
Hi Lisa, that was really good. Can I ask about dentistry? Because that seems to be a bit of a problem nationally, and I was just wondering what your thoughts were in terms of ICBs providing things like NHS dentists, because it seems to be just a bit of an issue.
It's the dentistry I mentioned was the sort of secondary dentistry, which is dentistry that happens in acute trusts. So that was previously commissioned by NHS England and has now moved to the ICB. It was always a bit odd that I think that it was held up there centrally. So these are sort of trust dentists, but community dentistry, I have to be honest, Jacqueline, it's not something that I've got much expertise in.
No, thanks for that. Thanks for updating me there.
Okay. Joyce.
Hi, I was just wondering, how often do they review funding and commissions, especially at the moment with the growing number of mental health need and fewer services?
Yeah, it is definitely an annual process at the moment. So all organisations will submit an annual plan to the ICB, and then the ICB will either sign it off or not sign it off, or work with you in order to do it. But absolutely, when you're commissioning, there will be money that will be ring fenced for specific pressures that you think may come up, and of course sometimes during the year additional funding will be made available. So you may have all heard of winter pressures funding, or different pots of money that might happen in the year, but essentially providers and the ICB are expected to live within their financial allocation for that year and not expect that there'll be additional funding. Okay.
I think there's still a question on there from the timeline for specialised commissioning coming across from NHSE.
Yeah, I believe it's happening next year.
And again, I think it's they're doing it in tranches. So there are certain specialised commission services that are staying with NHS England for the time being. So they're doing a first lot, second lot over a period of time.
Yes, I think highly specialised will remain. And that's the sort of, as you said, was it the ECMO and those sorts of services that are highly specialist will probably remain that, because there's only sort of 5 centres in the country.
Great, thank you very much. Are there any other questions? And to time as well, you've managed to catch up my time that I'm going over. So thank you again.
You're very welcome.
Okay, I think we're due a screen break now. So it's 10 minutes screen break. I think then Tash is going to come back and introduce Mike's Patrick McGinley, who's going to be talking about NHS costing and PLICs within mental health. He's the head of costing and service line reporting at Maidstone Tunbridge Wells, who's going to cover that. I'm going to log off and go to another meeting, and I will see people back if they're coming back for their procurement talk, which I'm filling in for. But if not, 10-minute screen break. And just a reminder for any of the medics on the call, if you haven't already done so, if you could fill in the pre-teaching questionnaire, the link is further up in the chat. That would be great. If not, if you could send us, just let us know, and I'll send it back to you, the link for the pre-teaching questionnaire to help us gather some information about what people's training's like and what we can do in the future. So thank you very much. Tasha will see you in 10 minutes.
Yeah. Hi, Patrick. You okay? You're on mute.
I'm on mute.
Yeah,
Shocking. Shocking. How are you, Tash?
good. Thank you. I'm covering today for Becky.
Ah, see, she's clearly using the cream floating to the top, because originally she said, "Oh, I can't make it, but I'll get Sophie to do it," and now she's worked through Sophie and gone, "I'll get Tash to do it. That'll be grand."
Yeah, she's at Glastonbury this weekend.
Is just shocking. She turned us
I
over for
know.
Glasgow. That's appalling.
I know I'd be picking Demystifying over Glastonbury anyway.
Yes.
Um,
Could have gone down later.
we're just on a break, so we're going to start in a few minutes.
Yeah. No, I just caught the end of Elisa, so I have been on for a couple of minutes just to make sure I could get there.
Your connection is slightly off.
Is it?
It says poor network quality, and you're a bit buffery.
Oh, that could be a pain. It has been a little bit thundery here, and once it gets a bit atmospheric, then our electrics tend to follow it, and that affects the broadband.
That makes sense.
Yeah.
I mean, you're fine right now. It just has little moments.
Yeah, I'm happy to turn the camera off. That might be a pleasure for everyone.
I mean, if it works and it's better. Have you got your slides? Did you want me to share them for you?
Could you share them for me?
You did send them over, didn't you?
I did. I sent them to Becky.
Yeah, that's fine.
I think I did it last Friday, if that helps.
I've got them.
Cool.
All good? Can you see it?
Yep, that's cool. Yep.
Your connection's much better, by the way.
No,
it's good. It's better. It's better.
They're just saying that till the pressure comes on. We've been having awful network problems at the hospital, and we're now reduced to asking staff whether they might, finance staff, whether they might want to come in this weekend to do the transactions then, because it's taking 2 hours to save a file during the day.
Wow.
And our only downside is that we've got no guarantee that if they do come in Saturday and Sunday, that it will be any quicker.
Oh God. Hopefully it gets sorted.
Yeah. I think it was the classic. We upgraded some servers to increase speed about 4 weeks ago. And I think we've increased the speed, but we didn't do anything to change the storage. And I think the transactions are just flying into the storage memory much quicker now, and then rebounding because they don't have enough capacity to save. So classic. Oh yeah, this will improve things. Oh no, it hasn't.
At least they tried.
They tried, yes, at a cost of several hundred thousands of pounds, which will now take a couple of million to sort out. So, but we'll get that from mental health. That'll be fine.
Good. It's 7 minutes past, and I believe everyone's back off their break if you would like to get started. So we're joined by Patrick McGinley, who's going to be talking around costing mental health services. I'm not sure how you want to play it, if you want to do some questions during or wait until the end.
I'm very happy to take questions during, and also very happy to take them at the end. I am hoping that I provoke some questions, even if they are only of the "is that it" type. But no, if people actually think I've said something far too controversial during the slide, please put your hand up, chat, whatever. Some of it is designed to provoke some reaction.
Perfect. Well, I'll pass it on to you then.
Okay, thank you very much, Tash. As Tash said, I'm Patrick McGinley, and I think as AK said just before the break, I'm Head of Costing and Service Line Reporting at Maidstone and Tunbridge Wells NHS Trust. For those of you who know Maidstone and Tunbridge Wells, you will know that we have no mental health services at all. We are not an integrated trust. We are not a mental health service trust. And we are a large acute trust. But I was and am involved with HFMA, the Healthcare Finance Managers Association, and NHS England in drawing up costing guidance for both acute and mental health services. And therefore, that's why I felt that I could come along this morning. So if we could move on to the next slide. I just wanted to give some sort of context to costing for several reasons. I'm a head of costing, therefore I need to justify my existence on a daily basis. Costing is an inherently historic process. I can only cost something when something has ended and the payments have been made. I can't cost what a bed day will be next Thursday because it will depend on the type of patient, how they're admitted, where they're admitted to, the number of staff that are on the ward overnight, and so on. And also whether they ask for pizza for dinner as opposed to shepherd's pie. Costing has been integrated within the NHS for probably about 30 years. It wasn't part of the original setup in 1948, and as you can tell, I was there in 1948, so I'm aware of that one. And we've tried to do costing in several ways in the health service. We started off with looking at specialty costing, so we tried to find out what was the cost of general medicine or orthopedics or general surgery or mental health services, which are less well defined. We moved through that overall figure, and we didn't really care how many patients we saw within those specialties. We just wanted to know what the cost of the specialty was. We moved through that process to a top-down reference cost process where we still took the specialty costs first, but then divided it by the number of outpatients or the number of contacts or the number of bed days utilised in different weightings. And we're now at a process where we have a national cost collection that is based on a patient level costing. It's a bottom up costing. So we're trying to link the number of tests, the number of staff contacts, the number of therapy support contacts, the number of meals, the number of electricity units consumed on a ward, in order to give a fully fledged patient bill, would be one way of putting it. I think it needs to be said that costing is one of the two mandatory actions that you need to undertake as a trust in order to maintain your operating license by NHSE as the regulator. Annual accounts are the other one, and there are hundreds of people involved in producing annual accounts. Costing is the second mandatory action, and usually the costing teams within trusts are sort of 1, 2, or 3 people in total volume. So there's a lot of work being done by other people, not by the costing team. If we could have the next slide, please, Tash. As I've said, the mandatory costs are regulated by NHSE, so you have to make a costing return and you have to get your board to sign it off as being true and fair, in the same way that you could do with the annual accounts. And some items like private patients, health education, research are excluded as not being healthcare. They're other things. They're health education, they're research, they're private and therefore not part of the national health system. And for each of those headings, the cost of the service is assumed to be the same as the income. So if you receive £12 million for health education for junior doctors, it is assumed that it costs you £12 million. I think this is quite a heroic assumption, but those are the rules that we live within for the national cost collection. They're fully absorbed costs, and that means that it's not just the sort of direct medical, nursing, therapy, clinical colleagues that are involved, but also pathology, pharmacy, imaging. And the bit that everybody celebrates is that it also includes all the overheads. So it is about how we apportion and allocate heating, lighting, the chief executive, those parasites from finance, and HR. And in every organisation, HR is there to make finance look good, and that's quite an important function to remember. And that, I think, goes to the heart of the challenge for all trusts, whether they're mental health, acute, community, integrated. How do you identify an appropriate cost driver for those functions? And that applies to clinical support just as much. We might know that a therapy contact costs £30 for half an hour. Do we prorata it if we've got a contact that lasts 15 minutes or 37 minutes or 41 minutes or 11 minutes and 15 seconds? Is that quite reasonable? Is it rational? But also, what drives the overhead apportionment? Is it the space that's used? Is it the contact held within them? If only 2 patients turn up for an outpatient clinic, do we divide it equally between the 2? Do we prorata that between those? Do we try and find some way of charging the people that didn't turn up? Which I think is fraught with danger and difficulty. So I think from that, what I'm hoping we've got, and answers Kathleen's question, is that costing is about apportioning all of the spend that we've incurred to a patient-focused contact in some way. And part of the difficulty is defining that patient contact, and that becomes a challenge. So if we could have the next slide, please. And this goes on from that point, I think, is that it's the appropriate clinical classification that might be the challenge for the denominator. We're pretty good, and when I say pretty good, we're absolutely brilliant at recording all the money we've spent. It's what we've been good at since 1948. It's what we divide it by to get a cost that becomes interesting, would be the obvious word to use. But that difference between what we can cost, what we can measure, and what we should cost. Is it important to know the cost of a bed day? It's relatively easy to count as long as we register when a patient went onto a ward, when a patient came off a ward. We have a time. Bed days are measured at midnight. Therefore, if you're admitted at 3 o'clock in the morning and discharged at 9 o'clock in the evening, you have a 0 length of stay because you didn't pass at midnight. But is that clinically appropriate to know that? I think it's much easier within an acute setting. Largely my working life has been in an acute setting, so I would say that. We're very geared up as a health service overall towards admission dates, admission discharges, dates on which patients come to outpatients, dates on which we make contacts with patients. We're very good at recording that. We're much, much, much less good at recording the diagnosis associated with contacts. Very good for admitted patient care, for outpatients and for community contacts. There is no way of actually inputting a diagnosis onto the data set that is submitted for recording outpatients or community contacts. And of course, where we're very poor is in the areas in mental health where they're differently configured. They're not largely set up for acute admissions. There are some, and I think the next slide will show that. But actually, it's much more about a costing of a contact, because that's what we're recording. and very much less about what is the expected output from that contact, and therefore what is the point of the costing. So if we could have the next slide, please, Tash. I think we can encapsulate some of the challenges here. Sophie, you've got your hand up.
Hi, sorry, I'm a little bit lost
Okay.
about what you mean. I know what a denominator is, but what you mean in the context of costing, I don't really understand that.
Okay, it's absolutely my fault. In that, in order to have a figure that says it costs £700 to be in hospital for a bed day, which for an acute trust is a typical figure, I've got to have a denominator of bed days to divide it by. So I know I've spent £1 million. How many bed days have I used in order to come up with an average cost of £700 per day? And it's just that's the denominator. I could use outpatient attendances. I could use A&E attendances. I could use IOPT contacts. I could use admissions. But it's finding that denominator of what am I costing within this specialty or within this function or within this patient experience, and that becomes a difficulty.
So in that context, then, if we're talking about bed days, what's the nominator?
The total cost might be the cost of medical time and nursing time, clinical support, but then how many bed days in terms of patients in a bed at midnight have I got on this ward over a week, month, year, or whatever.
Okay, thank you. That makes sense.
Yeah. Okay. Thank you for the question, Sophie. And that actually leads on really well to this slide that I've put up as the challenge, I think, for costing for mental health in particular. This comes from NHS England and shows the dashboard for monthly statistics for mental health services. It's for the whole of NHS England. What we see in the top left-hand corner, the figure 1612879. Accountants love a number. That's the number of patients who have been in contact with mental health services within NHS England in the month of July 2022. And on the right-hand side, there's a figure of 2,234,080. And that is the number of contacts within July 2022 that the 1,612,000 patients had. So on average, each patient who has been in contact with mental health services has had, something like 1.3 contacts in the month. In the middle, the 22,839, that's the number of hospital spells. So that's the admissions to discharge for mental health services, again in July 2022. The challenge here, I think, is that there's obviously a huge discrepancy between the 22,000 admitted spells in a month and the 2.2 million contacts. And I think, particularly for mental health services, it's the fact that that is the big discrepancy. If you looked at acute services, you would probably find that the ratio is, 40% of contacts had some sort of hospital admission. So there's a lot of work there that isn't undertaken in a hospital setting or a traditional bed-driven setting. The other challenge is this is reported in March 2023. So the most recent published data from March 2023 refers to data in July 2022. So what happened in August and September and October? And by the time we find that, we'll be in 24-25. And building on Elisa's presentation before the break in terms of commissioning, how do we cost this service, but how do we commission it? Are we going to commission for the bed days? Are we going to commission for the ward capacities? Are we going to commission for the contacts? And what form of contact is that? Is it face-to-face? Is it telephone? Is it virtual? Is it, and inevitably it will be, is it a mixture? And that ratio, it's just a single data point. Is that good or bad? Do we expect everybody to have at least one contact? Do we expect some cohorts of patients to have 5 or 10 or 15 within a month? And that becomes difficult. And the costing challenge is the same, I think, as the commissioning challenge here of what is it that we're defining, and absolutely going back to the point about finding an appropriate denominator. What would look good? As Sophie asked, what is an appropriate denominator, both for costing and for clinical treatment? And if we move on to the next slide, Tash. And you will be getting a copy of these slides, but this slide actually shows something that as an acute costing practitioner, I'm rather happier with, because it's a length of stay broken down by age of patient, whether they're over 55, between 18 and 55, or below the age of 18. So I can see number of bed days by month. That I think becomes easier to cost. That I've got this recorded activity. I know somebody was in a bed at a particular time for a length of stay. I can do a start, I can do a finish. And that may be easier to cost because I could do the cost of the admission, or I could do the cost of the day, or I could do the cost of the total stay. But exactly the point I think that Joyce has brought up, there won't be very many occasions where you'd have multiple stays within a month. You may have multiple stays over a longer period, a quarter, a year, a decade, or whatever. And that challenge, therefore, is if this is such a small part, this was part of the 22,000 admissions in the month of July 2022. The balance of contacts is likely to be more informal, likely to be less well recorded, I would argue, especially if we're looking at telephones, if we're looking at Teams calls, if we're looking at virtual contacts. And how do, from the patient experience, is it important to know that it costs £87.15 for the first contact and £91.72 for the follow-up contact, and then a £36.12 and then a £219? No, I think the challenge for all of us is, what am I expecting to get out of that contact, and how does it compare to that cost that I can calculate based on the recorded length of the contact or the environment of the contact, whether it's in an expensive hospital, or if it's on the phone, or if it's from home. How many am I expecting to have in a month? So if we go on to what I hope is the final slide, I think this goes to the point that Joyce was raising in the chat about multiple contacts, because I think the reason that we cost, the reason I'm interested in costing, is it's a financial way of assessing value. I've got a pound note, I've spent it. For kids today, we used to have currency that had printed on paper rather than coins. And if we can't assess value because we don't record the cost, how do we know that we're doing something clinically meaningful? And that goes, I think, particularly to the heart of costing mental health services. What are we expecting to get out? Is that value of the intervention in whatever form? Can we assess whether that intervention outweighed the costs associated with the intervention? And I don't think for any service, but particularly for mental health services, that counting what we can count is necessarily what we want to do. I think what we want to be able to do is find the intervention that is most appropriate for the patient that we're seeing. And is that contact necessarily in an acute setting? Is it in a bed setting? No, I don't think it is, although, much of popular television is still set in hospitals. But can we find a measure that goes back to the earlier questions about an appropriate denominator. Not just what we can count, but what we should count. And what form did the contact take, and what was the outcome? Ooh, Saoirse, you've put in an acronym that I don't recognise.
The Work and Social Adjustment Scale. So it's one of the clinical outcomes we use within SLAM, at least, which measures. I mean, if you're talking about cost, it's often about functioning. It's about the humanity of the person. Are they working? Yes. Are they able to stay out of hospital? Are they able to look after their children? Are they able to get to the gym and not use diabetes medication? That kind of stuff. And the work and social adjustment scale measures that in a very crude way. And it's one of the scales we found that shows the most progress when people come into our service as a specialist therapy service. Because as you say, the cost is really about a more global thing. What is it costing the state, as opposed to what is it costing the mental health trust per se? So that's just one suggestion.
No, I'm a cost accountant. Crude is our middle name, because I think many of the measures that we have had for many years are exactly that. They are crude. And I think one of the challenges we've got is that lots of the finances, both from contracting but through costing and annual accounts, are laid down by legislation. We have to make a costing return, and it has to be what our trust spent. But it doesn't take into exactly those points that you've just made, Saoirse, about the wider benefits of our involvement, that we allow people that we are dealing with to have more fulfilled lives, because we can't count that measure, because we can only divide it by the cost of what we spent rather than what society benefited from. But it doesn't stop us saying, actually, what would costing look like if we had integrated the work and social adjustment scale? How could we do that? What does that mean for us? Because I think that is a value to clinicians, but it's a value to the trust that they're working within, that actually we can start seeing this benefit of intervention is greater than the cost. And that's why we're here, isn't it? And that's why I think costing is important, because it's the baseline. And then let's assess whether what we're doing is worthwhile. And it almost inevitably is. And is there a better way of doing it? And there quite often is as well. And that was about the end of my presentation. So are there any other questions? Otherwise, I'll ask Saoirse whether she's been able to integrate the work and social adjustment into a costing. And
well, my question to you would be, given your area of expertise, what do you think could be the ways we tackle this? What are the possibilities that, as mental health trusts, we could start thinking about implementing?
Well, blimey, I've only got 10 minutes left, so I'll barely blather my way through the introduction here. From my perspective, I think there's probably 2 or 3 elements that I think are really important. One is, what is a better way of costing within mental health services? Because they have not been costed well ever, and they still aren't being costed well. Secondly, is there an opportunity within the existence of integrated care boards now to draw on that wider information, that wider social aspect of local government, of local care, that we can start saying this is an impact? Amongst my many crimes against humanity, I sit on the Strategic Council for the All-Party Parliamentary Group on Obesity. And one of the things we're trying to do there is to show that investment in services that support people living with obesity actually have a benefit elsewhere, in the workplace, in education, in their local lives. But finding the right measures is difficult there. But I also think there's a role for the Integrated Care Board in actually saying, let's stop having our acute and mental health and community silos and see how we link those together. One aspect that we're exploring locally in Kent and Medway is the obvious link between poor mental health and poor physical outcomes. Has long been documented, but I'm not sure we know what the drivers are for that. So what can we do in areas possibly like maternity services, where mothers attending the mental health mother and baby unit have already had a physical health intervention, but how does that affect the cost of that intervention and the future costs of interventions? And is there a link there between areas like postnatal depression and earlier onset of a variety of cancers, for instance? So can we actually stop thinking of people as falling within an acute costing silo or a mental health costing silo, and actually say, what's the cost of the whole patient and all of their contacts with the health service, rather than are we good at counting when they were on a ward, or when they attended an outpatient, or when we phoned them, or when we had somebody visit them, and actually say, what are we getting for everyone? And I think there is a role there of costing, of actually saying, we're already incurring that. How do we spend that money better? Rather than less of it, but how do we spend it better? Did that go anyway to answering that question, which was a good question and a crap answer, I suspect.
Right. I think there, like, for instance, King's collaborates a lot with SLAM over the King's partnership in terms of taking the physical and mental health overlap. And then early intervention services seem to be, when you think about kind of costings and things, the EI services and psychoses, that's one of their big drivers. That's been one of their ways of saying, look at the reduced amount of admissions, look at the reduced sort of tax on society. So it feels like some of that research is there, but I think my experience as a clinician with very little understanding of finances, when I hear how finance decisions are made, it's often made outside of the context of the mental health individual.
Absolutely.
And so they just cut costs and take away care coordinators or support workers that then create a situation where people end up in hospitals and stuff. So I suppose it'd be interesting to have, for me to think, how can they get the voice of the practitioners onto the finance boards to help them think about that? And then research backs it up, like whether it's the early intervention research or specific areas. We can anecdotally, as a small service, say certain patients we see as an outpatient service stop getting admitted to inpatient services. But it's on an individual basis, which is why the WASAS is the one we can kind of use more crudely across all our patients. There's definitely work to do.
You've never said a truer word. Absolutely, but I think I have high hopes that if we get the integrated care boards right, and I don't think we have yet, but if we get them right, then actually that's exactly what should be coming out. And we shouldn't be saying, here's our 2.2 billion for acute care, and here's our 800 million for mental health services, and here's our 400 million for community services. We should be saying, what are we trying to provide across all of these services? How do we link them better? How do we make sure they work closer together? And how do we avoid the really expensive stuff, which is going into a bed? Anything short, seriously, whatever services we're using, if you're in a bed, it's 700 quid a day minimum. You can do a lot of outpatient intervention for 700 quid a day per patient per day. Are there any other questions? If not, Tash, I think I've fulfilled my brief. I did get some questions, and they were really, really good questions.
Thank you so much for your time today. If there isn't any more questions, then we'll move on, if that's okay. I can see Henry's on the call. Hi, Henry, are you okay? We're going to be
Hi,
hearing
Tash. Yep, sorry, I was just on mute. Yep, hi. How you
No,
doing?
that's all good, don't worry. If we move on to your section, then I don't believe we have a
Yep.
break now. AK is on a call right now. Usually he would chair these sessions. But,
Okay.
I'll do it instead. We're
No
going to move
worries.
on to Henry Black now, who will be talking about the journey to the ICS.
Brilliant. Thank you, Tash. So, hi everyone. My name's Henry Black. As Tasha said, I'm the Chief Finance Officer for NHS North East London, or otherwise known as North East London ICS. Will someone be showing the slides in a sec? Great. Thanks, Natasha. Brilliant. So, I'm going to talk a bit about commissioning. I know there was a slot specifically on commissioning earlier in the day. So I will try not to repeat or hopefully not contradict anything that Eliza said, but unfortunately I wasn't actually able to attend that bit, so I can't guarantee that's the case, but fingers crossed so it won't be too repetitive. I suspect there's a broad range of people with different levels of knowledge that they bring to this session on the call, so I'll also try and strike the balance between being too kind of technical and detailed and stating stuff that is stating the obvious. But in order to understand the journey to integrated care and what integrated care is all about, I do need to talk a bit about commissioning. So what commissioning is, how it's changed over the past 5 years or so, and culminating in the Health and Social Care Act of 2022, which disestablished the old CCGs and set up the new integrated care systems and the integrated care boards. But before I sort of go straight into that, I guess in the spirit of demystifying finance, I'm aware that many clinicians and frontline workers who might be on the call, the idea of having a 25-minute talk about infrastructure and commissioning architecture of NHS England and ICSs could be all a bit white noise. But what I'd say about integrated care is it does what it says on the tin. It is literally what it means, or at least that's what it's meant to. It's meant to be about bringing together all of the different bits of the health and care system and getting them to work in a much more integrated way. So if you think about most of the high intensity users of the NHS, so people with long-term conditions, and then you think about the Marmot principles of wider determinants of health, many of those people who are the highest intensity users have multiple contacts with a range of different services and different frontline clinicians and other health and care providers. So from their GP, their pharmacist, they might get a visit from a district nurse once or twice a week. They might get the occasional visit from a specialist nurse. They might get a daily visit from adult social care, and then occasionally they will visit hospital, either as an outpatient or in some cases as an emergency inpatient. And all of these different clinicians are all employed by different organizations. And very often in the past, in the old system of the kind of internal market, patient experience and the quality of care was pretty poor and severely compromised by that kind of interface between different organizations and the handoffs and the kind of the way that people would be passed from one organization to another, potentially have to repeat all of their case history, not know who they were going to see next, but poor communication between different bits of the system. So that would tend towards a kind of more fragmented system and lead to episodic care rather than a holistic care, which is what we would all like to see for those people. So the fundamental principle of integrated care and the idea behind creating ICSs and integrated care systems and ICBs is to join those organizations up and ensure that care is provided more seamlessly, with the ultimate aim for patients to be cared as far as possible in their own home and only to attend hospital in a planned way. And ideally the kind of dream, which some systems are working towards, and some countries do this quite well, in fact, where pretty much all hospital visits are effectively planned on a planned pathway rather than a non-elective. And as we all know, over the last winter, we see far too many patients who are kind of frail and elderly, who are known to the system and known by their GP, but they end up as being picked up by the ambulance as non-elective emergency admissions, when actually their care would much better have been managed in a more coordinated way. So without further ado, I'll just go straight into the slides. So Tasha, if we could have slide 1. So this is effectively, when we talk about the internal market, that's the old provider and commissioner split. So we used to have CCGs, before then PCTs, and going back into the past, old health authorities that were separate NHS bodies that had the sole responsibility for commissioning. The idea of, and they would then have very kind of contractual based relationships with providers, and we'd go through these annual contracting rounds where everyone would have a big bun fight, and it was all very toxic. The idea of the ICS is to bring all partners around at the single table. So on the ICB unitary board, there is membership from providers, local authorities, and the third sector. That was not legally allowed before 2022 with CCGs. Providers were not allowed to be members of CCG boards. There was a commercial conflict that was considered to make that not allowable. So the law had to be changed. We had to have primary legislation to change that. And now an ICB unitary board has providers, local authorities, and all of those partners around the same table. And the idea then is that you're bringing social care and local authorities in particular. It means that we start to see our patients as citizens and bring our communities together and allow the residents in those communities to be much more in control of those decisions. This is all, I should add, and it's fairly obvious to say, but this is all the kind of theoretical practice, I'm sure, or so the theory. I'm sure in practice, people will have lots of examples where this doesn't happen, but this is how it ought to happen in theory, and this is the way that the legislation has been set up to do that. And so decisions around the allocation of resources should be based on need and not historic spend. So all of the way that we should plan allocation of resources and the financial flows should all go back to a kind of the JSNA approach, based on the local authority assessment of need, rather than just looking at the way that the current infrastructure spends the money and then effectively rolling it over from one year to the next. If we move to the next slide, this is just a very quick and probably impossible to understand. So I will try and kind of, in the spirit of demystifying it, this is what the old world looked like with CCGs receiving the budget from the Department of Health and Social Care via NHS England, and it would flow down to CCGs. CCGs would then hold that budget, and I've blown up the kind of box. This is from the King's Fund pre ICB. This is how CCGs used to work, and I've blown up that box that explains that CCGs would assess the health needs of their local population and make decisions about the health and care services they need. So in other words, that would be done by one small part of the system rather than everyone collectively coming together and making those decisions. They would then buy services from providers like hospitals, GPs, mental health, community, and other providers. So that I've emphasized the word buy because it does feel incredibly transactional and not at all in line with what we would all consider to be a kind of allocation of resources based on the way that care needs to be provided. The concept of a CCG buying from a provider, even now, we've not been in an ICS for even for a year yet, and even now that just feels very, very kind of outdated. It must be, it ought to be a partnership rather than a transactional relationship. So the next slide sets out how the new integrated care partnership works. So there's a kind of similar flow of funding that comes from NHS England down to the ICB, which is the replacement for the CCG. But that board has membership of, rather than being a separate commissioning organisation, has membership from the other partners in the system. There is then another statutory body called or a statutory committee called the ICP, the Integrated Care Partnership. That's a much broader representative body from wider local partners. It has the same members on it, but it includes much broader and is a much bigger organisation, or not organisation, but a bigger committee, a bigger body. And its role is to be much more strategic. The ICB is about getting the business done, so it's a much smaller body and more agile. Within the ICS, we have a series of kind of structures which are designed to support integration. So we've got the two that I would pick out mainly are the provider collaboratives and the place-based partnerships. So within place, which is the kind of geographically is a kind of borough level for within London, or a kind of county council, generally speaking. Sometimes bigger county councils will have more than one place, but it covers a population of between 250,000 and 500,000, depending on the kind of the makeup of that local geography, and it tends to sit around either a medium-sized city or a bigger city will have possibly 2 places. The place-based partnerships really are where those local partners come together. It's a non-statutory committee, but it's where partners come together. So around a place partnership table will be members from the integrated local provider partners, third sector, and community partners, and that's where that kind of what I would describe as the kind of vertical integration. So in other words, vertically within one particular place, all of the partners around that place are coming together and integrating. So that's the kind of vertical integration. If you then look at the provider collaboratives, that's the horizontal integration. So in other words, all of the partners within a particular part of the system, so the care system, so the acute, mental health, primary care, community, will then collaborate across the much broader footprint across the ICS. So that will be over a geography of 1 to 2 million. So that will be around things like managing specialist care, cancer care, those kind of things, some of the more forensic aspects of mental health, maternity services, and some urgent care around hubs and spokes, and managing that kind of some of those the design of services that needs to be done over a bigger footprint. So that's the kind of horizontal collaboration versus vertical collaboration that happens at place. In the box on the right saying what's different, so it's not a separate commissioning organisation. Technically, the ICB is a legal body that is separate from the providers legally, but there is all the duty to collaborate, and the providers are members of that board. So it is very much about partnership working at place and decision making that is distributed between partners, and placing a much broader kind of governance, much broader membership of that decision making. Next slide, please. Excuse me. I've also got a bit of a summer cold, so I'm slightly losing my voice. So this slide, you probably don't want to spend too much time looking at this, but this sets out some of the kind of the characteristics of the ICB, what it's there to do, its main functions, who's on the board, so chief exec, CFO, director of nursing, medical director. The old CCGs didn't have, most of them had chief nursing officers, but it wasn't mandatory. But they didn't have a medical director in the same way that ICBs do now. And like I say, they didn't have members of the local providers, FTs, GPs. They had GPs on them on the CCG. The CCG was basically run by general practice. If people remember the Lansley reforms, that placed general practice as the kind of effectively the members of the old CCGs, but also local councils and third sector. And then there's a bit there about the reserve functions that the ICB has to do at the board level versus some of those functions that can be delegated down to the individual places or the provider collaboratives. Next slide. Again, a bit more detail on what place-based partnerships are. So this is a map of North East London for people who aren't familiar with it. So that total map, all of the yellow, the pink, and the green, that is the whole of the North East London ICS. We have 7 places that cover 8 local authorities, which includes the city in Hackney, which is the London Borough of Hackney partnering up with the City of London Corporation as one place, because the City of London Corporation is effectively the square mile of the city, which has got, I think, about 20 or 30,000 inhabitants, not big enough to be its own place. You can see that historically we used to operate across 3 kind of sub-regional levels, and we now operate at the North East London level and then the place level. So what the places are there to do is to effectively, as I said before, bring together the partners, ensure that local authorities who have a much better understanding of the community that they serve and the needs that those patients have, and we need care to be delivered in a way that meets not just a kind of a narrow, clinically driven is crucial, but not purely medicalized way of delivering care, and that care is delivered in a as holistic a way as possible, using people's, as I say, keeping people at home, and the best way of doing that is to have those partners around the table. Next slide, please. And I refer to the provider collaboratives as being effectively the kind of cross-cutting, so the horizontal collaboration. So we have 3 acute providers in North East London. We've got Barts Health, we've got the Homerton Hospital and BHIUT. And the idea is that there is a great deal of benefit to be gained from those 3 hospitals or those 3 trusts working much more collaboratively. They can work better to sometimes to share resources, to offer one another mutual aid, to have what we've described as the high volume, low complexity hubs that deal with that have managed to deal with the elective backlog much better. So creating a degree of specialization where certain bits of elective surgery can be done at higher volume in on certain sites. In the past, providers were very, very much set up to be competing against one another, and that's how the internal market would work. Commissioners would issue a kind of procurement notice for a service, and then the providers would bid against each other. And we had the slightly ridiculous situation where providers from one part of the system or even one part of the country would then win a procurement bid, undercutting the local hospital, and would then provide the service for patients within that system that would be much better being done by the local provider. So we're moving away from that competition and much more towards collaboration and working collectively together to share those resources to better plan resources across the wider footprint. Maternity is a really good example where you won't necessarily have the the kind of capacity to have a kind of maternity unit in every place, and it might be much better to have to manage the maternity network across a wider footprint. Other examples would be things like in London we had the cancer cardiac collaboration, which and the creation of the hyperacute stroke units. The HASUs is another really good example of where quality and outcomes have massively improved by having collaboration across a wider footprint and coordinating that care through a smaller number of sites that are much more specialist and where the capacity can be kind of brought together. So that's where provider collaboration is taking the place of competition. Next slide. Clinical networks are absolutely crucial to underpinning all of this. It's crucial that the specialist clinicians in one part of the system working for one acute trust work together with their counterparts in another acute trust in another part of the system, or in the mental health, or this is the case across all aspects of clinical specialization and clinical care, particularly when it comes to specialized services. So you have a kind of a seamless, the idea being you have a seamless kind of internal referrals with those specialists working together, regardless of whether they work for hospital A or hospital B, and much more with the patient at the heart of everything that they do, but with all the services being managed primarily through the best use of the specialist clinical knowledge that we have. And that's all managed by the clinical advisory group, the CAG, which sits across North East London and has input from all aspects of the medical, nursing, psychological, mental health, and AHPs, and all clinicians are part of that CAG. Next slide, please. I think we might be getting to the end of my slides. Yeah, this is a bit more detail, which again is probably at this time of day, just before you have your lunch, is probably designed to make you feel slightly sick. So this is about. I will move on from this quite quickly, but this is just kind of describing the way that clinical and care professional leadership across the ICS takes the kind of forefront and working with the kind of management side of things to design services with clinicians and care professionals, absolutely at the heart of the way that services run. I did note I came in right towards the end of the costing session just now, but I heard the very interesting discussion between, I think it's Saoirse, was talking about decisions that are made to effectively cut resources without clinicians being involved, and that's completely crazy and should never happen. It's crucial that clinicians working hand in hand in hand with managers, but also being led by patient kind of considerations and the patient input, but issues around being accountable for the resources that are spent, that must be that accountability and that autonomy and that ability to make those decisions must be delegated down to frontline clinicians. Otherwise, because they're the ones who spend the money, and that's otherwise we will continue to have those ridiculous decisions that are made where what looks like a short-term saving of a few $100K ends up costing millions and millions more over the longer term. And then I think, is there one more slide, or have I come to the end? So this is just one last slide about population health. So population health, I'm sure, is something that people will be familiar with. In fact, I've got a couple more slides. I'm sorry, so that's fine. Population health is all about rather than managing care on, for, I guess, for putting it slightly crudely, in the past, care was managed at the convenience of the hospitals who provided that care, and very often at the convenience of the clinicians who provided that care, rather than hospitals feeling that they have a key role in improving the health of their population, not just treating the conditions that people present with when their health deteriorates. So using those in a broader context, using that clinical expertise to support preventative work effectively. One of our biggest challenges is around being able to create the headroom to invest in prevention, particularly given the financial challenges that we face at the moment. We have huge backlogs in elective care. We've just come through the worst winter in our history, and money is extremely tight. So being able to effectively kind of create some headroom to invest in prevention is crucial to ensure that we get ahead of that curve, and we ensure that the next generation of people coming through will have a better experience of care, and will be able to manage their conditions better, and ideally prevent those conditions from developing, or at least delay them developing until later in age. And then the final piece about population health is about what we call being part of an anchor system, being an anchor institute. So being an organization that is at the heart of improving the lives of our citizens, not just being the hospital where people go to when they're sick, but being a local employer, in some cases supporting the kind of development of community infrastructure, procurement for social value, so ensuring that local suppliers are given opportunities, and like I say, employment is probably the biggest single thing that the NHS can do to develop anchor as an anchor system, and to try to support local communities and train local people to become employees of the organisation. That doesn't only give people jobs; it also ensures that when people are admitted to hospital, the care that they receive is to a better degree provided by people who they feel connected to and they feel part of the same community. So it's a massively important thing. Moving quickly on, I will try and whiz through the next slides as quickly as possible. So this is how in North East London we have set our kind of strategic framework, our vision, our objectives, and how we have worked our priorities. We have 4 priorities. Obviously, everyone has about 1,000 priorities because everything has to be done, but we felt it was important to focus on 4 key priorities, which might not necessarily feel particularly health driven, and that's because they're deliberately not health driven. There are obviously health aspects to all of them, but it's deliberately intended to, I guess, chime with the idea of supporting local communities. So babies, children and young people, long-term conditions, mental health, and local employment and workforce. So that last one in particular, supporting our communities by being a good employer, and also by being a commissioner and a procurer of services from from organisations that are part of that employ people locally, and being part of that kind of improving local community infrastructure. Next slide. I won't dwell on this too much because this is getting into the detail. But in North East London, we have a specific, particular issue and an urgent kind of our urgent challenge is around our long-term growth. We are the fastest growing ICS in the country, or at least we're projected to be at this stage. Obviously, things can change, but over the next 15 to 20 years, North East London is expected to grow by around 380,000 people. That's based on the current levels of approved planning permission for developments. And that would mean that we would go from being 7 boroughs, we would have an additional borough's worth of people within those 7 boroughs, the equivalent of Barnet, which is London's largest borough. We also have incredibly tight infrastructure. We have the largest population growth is expected in 2 boroughs where there isn't, or there is 1 acute hospital between the 2 boroughs, so that we don't have an acute site in Barking and Dagenham, and yet that's our biggest area of growth. So that's a huge challenge. So all the more reason why working with local planning, local infrastructure, and attempting to work through how we resolve those issues collectively with our partners, and the regeneration around the Elizabeth line, if people are familiar with London, which used to be called Crossrail and is now the Elizabeth line, that runs straight through the middle of North East London and brings with it huge opportunities of regeneration, but also the likelihood of significant demographic growth. And so I think one last slide, which is just showing you how that distribution and that growth is all focused on that kind of that channel at the bottom of North East London, which is alongside the Thames. We have the Isle of Dogs, which is going to have density of population or density of housing and high and tall buildings, which is going to make it more densely populated than Hong Kong. We also have along Barking, which I talked about. There's a huge development which is being dubbed as Barcelona on Thames, because there will be a new embankment built there. It's currently all wasteland and all industrial sites that goes into the kind of muddy old docklands of the Thames. That will all be brand new suburban developments. All the more reason why, if we're going to manage now for the health population or the health needs of our population in the future, it's done on a whole population basis with our partners, with the local authorities, but particularly with the third sector where so much of our care is delivered. So, Natasha, I'm going to stop there and I'll open it up to questions. I know that's quite a lot that I've got through.
He's caught up in a meeting, so I'll be here if you need me, and I'll assist with Q&A at the end as well.
Lovely, thank
you. Just to introduce you, this is Natasha Ralston, Costing and Efficiency Accountant at East Lancashire Hospitals NHS Trust, and she'll be running through NHS costing and clicks today. So over to you, Natasha.
Thank you very much. I will share my screen and hope that it works as I want it to. So yeah, there we go. That's what I wanted. So yeah, hi everyone. As Natasha has said, I'm Natasha as well. And I'm the Costing and Efficiency Accountant at East Lancashire Hospitals. I'm going to give you a short introduction to NHS costing and PLICs from the acute side of things. So just a little bit about myself. I started my NHS finance journey in 2014, and I was just a finance officer with financial services at Merseycare. Then after that, a job opportunity arose in the costing team, and I was really excited to undertake it. It was something a bit different, and that's where I fell in love with costing. I then moved into income at St Helens and Knowsley, and I learned a lot about how income and costing are linked to each other, and how how costing is used to inform tariffs, and how income then plays a part in costing as well. But I still wanted to get back into costing, so in August last year I moved back to costing, and I'm now at East Lancs, and I'm really excited to be here today, so thank you. So what is costing? So costing quantifies the financial value of resources consumed in carrying out an activity. So resources, we use this term, and a resource is nurse, doctor, consumables, so like blood products, bandages, drugs. And then activity is what a patient has had done. So that might be they've had an inpatient spell, they've had a surgical procedure, you know, we've seen them as a follow-up appointment, they've had a pathology test. So it's all about how we can link those resource costs to activities, and then ultimately that then gives us a patient level cost. Within that, we also have, you know, overhead costs, which are your finance, your HR, everything that's a support service really, and corporate service that is in the background, but we have to allocate it in some way. So why is costing important? So it identifies why costs are incurred and where they're incurred, and areas where costs may be higher than others. It helps in developing improved patient pathways. So if we can see where costs are higher in one area than another, but it's a similar cohort of patients, we can look at the differences in that and try to understand why that may be. And is there any way to improve that, or actually spread those costs more evenly across the patients? It also helps in improving services and improving the value in healthcare. So we try and link this to, you know, patient outcomes. So what is the best outcome for the patient, and how can we ensure that we are using our money in the best way possible to get those values for that outcome for our patients. And then obviously we use it for benchmarking as well, so we can compare internally, so we can compare wards, you know, specialties, but we can also compare locally. So we work quite closely with our ICB to compare costs, and we can benchmark nationally, which is part of the annual return that we do. And this work then also feeds into the model hospital data uses PLIC. So we can see where, you know, where our costs sit against other providers, but also what that means in terms of patient outcome, because the cheapest option is not necessarily always the best option for the patient. So costing in the NHS. So we've got reference costs. So that was what our cost collection used to be. So it was traditionally very aggregated. You know, we'd get pools of activity and we'd put the cost into pools, and we'd say that would be the cost for that service, and that went on to inform national tariff. We now have the national cost collection, and this costs it right down to patient level. So we take all those costs right from finance, HR, all the way down to, you know, a particular drug that a patient's had, and we map that to each patient, and then we say, right, that is the cost of that patient for that activity. And then this is used to inform national tariff as well, but it's also used for benchmarking, and as I mentioned, it's used in the model hospital system. With the costing data, we can also analyse loss-making services. So as part of this, we pull income into the costing system to compare the cost of the services against the income we've received across the year. So obviously the last few years that's been a bit more difficult with the block contracts that have been in place due to COVID, but the idea is that we take the income for what was PBR and we match that to the patient, and we can say, okay, for that service it costs us X amount and we get X income, and therefore we either make a surplus or a deficit, and then we can start to understand why that's happening and what opportunities there are to try and reduce costs or maybe increase the income. We can also use data to identify readmissions. You know, we as a trust, we always want to understand why our patients have been readmitted, as well as the financial impact, but you know, that has a negative outcome for patients. We want to understand why that's happening in the first place, and with costing data we can do that. We can see how many times they've been in, what they've been in for, and we can start those conversations to understand why that patient has come back, you know, a few times. We can also recognise those longer stay patients. You know, we can see at what point they were admitted, at what point they were discharged, but because we can match, you know, pathology tests, radiology tests, drugs, all of that, procedures to a patient, we can see at what point they've had these during their stay, and then at what point those interventions may have stopped, to maybe understand Was it at that point that they were medically fit for discharge and now they're still in? And if so, why? So we can then start to ask these questions again, but understand, is it something that's potentially outside of our control, or is it something we could do differently to improve the service for the patient? And again, as we've mentioned several times already, we can use it for benchmarking. We can look at, variations in costs from one ward to another, from one trust to another. So it's really important that we actually have as much information as possible within our costing system. So moving on to how PLICs work. So every patient who is seen in a hospital setting will have a patient journey. That information is input into a number of different systems within the NHS, including NHS number and date of attendance, so we can see exactly when they attended A&E, for example, when they were admitted, when they've been seen as an outpatient, when they've been seen in the community, have they been seen by any mental health services, along with those support services such as radiology, therapies, pharmacy, theatre, pathology. So what has happened to a patient, that's all recorded within either an EPR system or a manual system. It might be a spreadsheet, it might be EMIS. We take all of this different data and we have to bring it into our costing system. So as I said, we take all of this data and it's collected from separate databases that are stored in the trust data warehouse, usually owned by the information team. And then as a costing team, we take this, we have an information person ourselves, and we pull this into our own server, our own database. And that's what we use the costing system Civica Costmaster for. Just 1 second, sorry. And because all of these systems are separate and all the data is not coming from one place, we have to match these patients together. And usually to do this, we take a unique identifier, and that for each patient is their NHS number or their local, PAS ID if you have one in your system. So we get the core feeds, which are A&E, inpatient, outpatients. Then we get all the support feeds, and we have rules of how we are going to match the support feeds to the main patients, the main patient data feeds, sorry. And what it will do is it'll take the start and end date of the core feed. So we know patient A was admitted on the 1st of April and was discharged on the 9th. So then what the system will do in the background is look at all those other feeds and say what happened in between those two dates to then match it back to that spell, which then allocates more of a cost to it. And then that gives us the whole patient journey. So along with the patient data, we also import our general ledger data into the costing system. And this includes the actual spend for that period, along with the PBR and non-PBR income that we've received. We have many different allocation methods set up in the costing system to ensure that the costs are being allocated to the correct patient for the appropriate amount based on what has been done. So for example, if we take one of our wards, which is Ward C9, we'll allocate the cost of our nurses that work on Ward C9 to all of the patients who had a spell or an episode on Ward C9 in that time period. And we'll do it based on length of stay. So if a patient was on for 10 days and another patient was on for 1 day, that first patient will get 10 times the amount of nursing costs compared to that patient who was on for 1 day. And as I mentioned earlier, we have the overheads as well that need to get allocated down to patient level. These are just based on actual spend on each cost centre and apportioned on a more generalised basis. We don't make these allocations up as we go along. We don't choose how these costs are allocated. When we come to do the national cost collection, we are given guidance by NHSI, and we have to follow that guidance when we are doing the cost collection and when we are producing PLICs on a quarterly basis. So that means that every trust in the country should be allocating their costs to patients in the same way. So this then gives us a more accurate way of benchmarking, but it also means that we are following standard practice. So we know we have satisfied that element. And if there's some variation, we have to explain that. So then once the system has apportioned all of the costs and income, it'll produce a patient bill for every patient. So the importance of accurate data. So these next few slides are just to demonstrate how important it is for us as a costing team for records to be inputted onto PAS systems, or however the data is being collected, in the most accurate way possible. So as you can see, we've got this first patient who had a hospital stay of 12 days. So when we run this data into our system, we found that they were showing costs of over £2.5 million for a 12-day length of stay. So that immediately jumps out to us because we would not expect that. That is far too high. So we can drill down into each patient and we can see the ward stay equated to, £5,500, about £457 a day. That's what we'd expect. We're happy with that. That feels comfortable. They have some pathology tests. Again, we're comfortable with that. The radiology exams are the same. They've had drugs, but then we get to the theatre costs. And this is at over 2.6 million. So we would never expect that. When we then drilled further into it, they were showing us being in theatres for 187 days. So we knew this wasn't correct and we needed to do something about it. So this is now going to show us the timeline of what happened with the theatre data. So they started in anaesthetics, they moved into the procedure ended, and then they moved into recovery. But we can see that the recovery end time was in October. So when the patient was discharged from hospital in April, that's clearly a data quality error and it needed to be resolved. So what did we do to correct this? So as a team for the cost collection, we manually corrected this in our costing system. So we knew what the data should have told us after meeting with the theatre team. So we were able to manually update this to be a recovery end time of, a couple of hours later. The theatre team actually are great. We've worked really well with them. They understand the impact of data being incorrectly entered, or, mistakes happen. We understand that. So they've been really helpful to actually check their data. But we also have put a rule into our system to identify any times that are over a time agreed with the theatre team. So the system automatically updates these dates, even if the theatres team hasn't had time to do so. So what this meant then, we corrected it and it actually brought the patient costs down to just under £12,000. And that's more in line to what we expected. And we can actually now benchmark this activity in a better way. And, we're happier with that cost. We're not going to be showing as an outlier. So I'm just going to move on now to visualizing data. Because we collate all of this data on a patient, there is so much that is available and so much to actually use to visualize and to take out to clinicians, to support services, to anybody in the trust really. So we need to ensure that we are visualizing this data in a way that's, clear to users, but also is going to be helpful. And to do this, we use Power BI. So we always start our Power BI reports at a divisional and specialty level, and we're able to drill it right down to patient level. So we can easily identify outliers of the data and even sections of data that may need work on because they're incorrect. And costing is always undergoing continuous improvement. We never settle on that being final. We're always looking to continually improve. So we need help from our clinical colleagues to understand when information doesn't look right, why that is, and what we can do to correct it. So just got a few examples of our Plix dashboards. So they're still work in progress. We have published these to the trust, but we're always looking to update them, looking for feedback to see where people may prefer a different way of visualizing data. So this is just cardiology. So we can see from this, just this section here, that C-Lab or Cath Lab is the highest ward, costing ward in cardiology, followed by B6, which I know is a cardiology ward as well. So we know that this is right. However, if, for example, we saw a ward here that was a trauma and orthopedic ward, we'd immediately question it to understand why has that been allocated to cardiology patients. So in this scenario, we'd start by looking at our own costing methodology to make sure it wasn't a rule in the system that we'd got wrong, before then going back to divisional colleagues. This one is for one of our most frequently asked questions. So it's, what is the cost of a particular ward per day? So we get this question a lot from the service improvement team, from clinical colleagues, from finance as well. So we've created this dashboard so that they can go on, they can drill, find out the ward they want, and then we can find out the cost. You can also see the average length of stay. You know, you can see what's the most common HRG group and specialty. And you can also see the trend of patients as well. So the green bar is the cost and the black line is the length of stay. So we can click on each of these elements and drill down. So this isn't live, I can't click on it now, unfortunately. And then this is just, we've drilled into a patient, so we can see that this patient's been in and out of this ward many times during the year. They spent a total of 84 days on ward C10. And we can see that their main costs have been respiratory, but they've also had COVID as well. So we can work with the directorate and the clinical coding to understand why the patient has been in and out of hospital so much. Is it a recurring illness that requires multiple stays in hospital? Or is there a different reason that perhaps needs addressing? Is there a care package that isn't in place out in the community that needs to be looked into? Or, have we missed something? It's all these questions that need answering, but by looking into the data and working with clinical colleagues, we should be able to get to the bottom of them. And then just one last thing to note is that costing is the only place in the trust where we pull all this information together from all the different data systems, applying cost and income to see patient journeys from start to finish. So it's a really rich data set, and it is something that is really, really helpful to colleagues, and it can be really valuable to trust. So yeah, any questions? I will just stop sharing so that I can see you all. So yeah, I can see someone. Is it Bijou?
Yes.
Yeah.
Hi, can you hear me?
Yeah, I can hear you.
Hi, my name is Bijou Terry. I'm an ED consultant at Hull. I just want to ask you, so from what you're saying, costing is often decided at the end of the patient journey, is that correct?
Yes.
And can that data be used to presumptively design pathways in the future? So, for instance, if I have a patient who comes into the emergency department with abdominal pain, and then I decide to do some blood tests and a CT scan, and all of that is costed at the end, and will that then help decide how much will it cost a patient who comes in with abdominal pain in the future?
Yes. So what we do as a trust in particular, we run quarterly data. So we can see, we've always tried to keep it as up to date as possible. So it's always going to be at the end of a spell or the end of attendance, but we should know that if you've had a patient within the first quarter of the year and it costs £300 to treat them, we generally expect it to be the same, but it can be used. It is a good way of putting cost to patients. We're always updating them, but it gives you a good benchmark to say, if we look back over previous years, the average is £300 per patient for that abdominal pain as an example. And we can see that it stayed fairly consistent. So yes, that is a good number to put on as a cost for that patient.
And just one more question. Within your trust, so when you follow a patient's journey, I know different trusts, they divide their health groups into, or directorates, like surgical health group or medical health group. So does that cost go to, is it applied to individual departments?
Yes, so we can see the cost for the whole patient, but if they've been in surgery for a portion, so if they've been in A&E for a portion, we can see just that cost and that will go to A&E. If they've been in surgery, the same thing will happen. So we can look at it in different ways, but each department will get the cost that is related to them.
In that patient's journey?
In that patient's journey, yeah.
Thank you. That's all.
Okay, no worries. Any other questions?
And there are a couple of questions in the chat.
Okay, thank you. Sorry.
That's all right. I'll read them out if you want. Did you use SPC charts to highlight variations in the data?
I don't think we have done, but you could do. We just tend to use Power BI as a way of drilling down, you know, taking it from that high level right down. The costing system that we use actually has reports where it will highlight outliers for us. They're built into the system. So they're probably using SPC in the background. It's just that we're not running it as a team. We just run the report and that gives us what we need to look at. But other than that, we use Power BI.
Okay, thank you. And other questions are, so I'm AK, I was chairing the day, but I logged in late. How is it costed if a patient is sent to another ward or hospital trust?
So if the patient is still within our trust, then it'll just get costed as per wherever they've been. If they're moving wards, that patient will move the wards in the system and the cost will be allocated based on wherever they've been within the hospital. If they are moved to another hospital or trust, that patient we'd say is discharged from us, so we would stop seeing their costs, but it would then move to another trust. If we have the relationship within our ICB where we could track that patient because we've started benchmarking at an ICB level. And I'm pretty sure there's a national PLIX portal where you could see patient journeys. So the idea being that with PLIX is that with an NHS number, you can see wherever they've been in the country and how much they've cost, but we don't report it if they've moved to another trust. We only see what has happened in our trust.
Okay, thank you. And a couple of other questions. Do you include just the revenue costs or any capital costs, such as in-year depreciation of the ward hospital?
So when we actually come to do the national cost collection, we have to do a reconciliation back to final accounts. So all of that gets taken into account. But when we are doing SLR, we do have a separate section which includes capital, but it's not necessarily allocated to patients. It's like taken off before that point. I hope that answers the question.
That's quite a high level question. And finally, I think we have a high length of stay due to lack of secondary rehab services available in our area. Is this considered with the costing and information shared for the need of secondary services?
I mean, yeah, absolutely. You know, your costing team should be considering that. You could use it then to build a case to take to the ICB or whoever's commissioning those secondary rehab services to say, look, these are the costs of these patients that don't have access to this service. And if they did, it would reduce 1 hour length of stay because presumably they're medically fit for discharge or to a certain extent. And we'd be able to see more patients, have better outcomes for these patients. So yeah, and that should show on model hospital as well, ultimately.
Thank you.
Okay.
I think a lot of the PLIX teams display the information. It's then up to the the clinical teams then to use that information
Yeah.
in a way to promote whatever, identify the issues, but then also help find the solutions.
Yeah.
And you'll be able to show that, the length of stay, due to lack of secondary rehab tends to be low. You don't get lots of interventions,
Yeah.
and so you get quite a flat kind of tail. That's a long tail on your kind of cost per day analysis, and you can show that, and you can show that that's where issues come about, and you can use that to kind of build your business case.
Yeah, absolutely. And please do, because that's what we're here for as costing teams. We should be out there giving you this information and helping you with this.
Oh, another question. When a patient is not in the right bed or ward, the additional costs, i.e. social care, hospital at home, would be apportioned to the general ward, thus potentially distorting the data for the service. How would this be captured?
So I suppose that's kind of what we were saying, in the sense of, if they're not in the right place, so they're still in hospital, but they should be receiving care in the community or have a social care package, we would carry on seeing those costs. But that would still be in the data, so you'd see, like you said, that tailing off. So that your costing team should be able to see those patients, and if you have patient numbers, then you should be able to go to your costing team with those to say, what do these look like in terms of cost? I hope that's answered your question. Sorry.
You can often see, you have your initial acute fact, and then you have his tail, and then after a while you might get secondary reinfections or other complications arising because they've been stuck in hospital for a while, and you can use all those costs then to highlight the issue. And if you can accumulate that by running, getting a report off, you can say that this is how much money would save by increasing the amount of rehab services. And again, it's about building that business case as a collaborative process.
Yeah.
Great. Thank you very much, Tasha.
You're welcome
for coming along and helping out today. It was very informative and very useful.
Thank you. I think we sent the slides, but if not, we're happy for the slides to be shared, so I can always send them again.
Thank you. I'll check with Tasha whether she's got the slides. But if not, she'll contact you.
Yeah, great. Thank you for having me. Thanks.
Thank you.
Bye.
I think the next session is on procurement. Normally we have one of the members of the HCSA team, which is the hospitals. I can't remember what they stand for now, but they have one of the national procurement services coming along to deliver the session. But instead, you've got me. So I'm going to be covering a very brief and relatively basic overview of procurement in the NHS. What we're going to be covering is what it is, how it works, a little bit about category towers and framework agreements, and something about buying goods in your organisation. Okay. So procurement is essentially the process of obtaining goods or services, and that can be medical services, clinical services, it can be equipment, it can be all kinds of things, and it kind of comes in different forms. It can be purchasing, hiring, leasing, or borrowing. So procurement covers a wide range of things. In some organisations, procurement separate to finance. Sometimes it's part of the finance team. So there's a bit of overlap, and it varies. There are lots of rules and regulations surrounding procurement. So the main one that applies to the NHS is the Public Contracts Regulations, which came in 2015. But it was based on it was basically transposing EU law into the UK law. And it sets the limits for what can be procured without too much faff, essentially lots of processes, and set the processes available. And there are various thresholds above which you have to do certain processes. But as we have left the EU, that no longer applies. And so there was going to be some sort of change over the next few years. And there is currently a procurement bill going through Parliament. It's having various amendments to it. The idea being it is going to be less regulatory. It's going to encourage small and medium businesses rather than big multinational corporations. When you look at procurement, it's going to encourage things like reinvestment in your local areas. So it's going to ensure that this is for all public procurement, not just for NHS ones, but that they look at the impact on reinvestment in the area, regeneration, so employment, housing, all that kind of stuff in the local area, as well as the kind of other benefits that you're looking for when you are doing procurement. So that's the current situation. There have been lots of amendments that have been tabled, both by the Lords and by the Commons. So I don't know exactly what's going on in terms of the stages of issues. It was last debated last week, and it'll probably be debated again in the next couple of weeks before it gets approved formally. Okay, so NHS procurement specifically, it essentially is all about how much the value of the contract. And that's what determines the rules that apply. And the exact process will vary between organisations. So different organisations have slightly different financial limits and thresholds above which they need to change the process. Where you can generally find these is in the standing financial instructions, which are normally released every year, and every organisation has them. And an example of one that you might find, so there's two bits to it. There's quite a complicated kind of financial instructions, but there's two bits of it relevant to procurement. There's the scheme of delegation, which just shows who needs to sign off on what things. So there'll be different things for, say, employment purposes. There'll be different thresholds for capital purchases. There'll be different thresholds for equipment purchases as to who can sign off it and which committee it needs to go through. And then the other side of it is the financial limits in terms of quotations, formal tenderings, and the minimum number of people of quotes you need. Okay, so for example, something between £10,000 and £75,000 in nature. This organisation wants 3 quotes to have a look at. Anything above £75,000. This organisation what needs a formal tender, including minimum of 4 companies or organisations that you invite to quote for. Okay, the PCR limit is that public contracts regulations limit. It changes every year. There's a different limit for central government as there is for the public kind of non-central government. So the current one for goods and services is about £230,000, and for works it's about £635,000 for NHS basically, which comprise the kind of non-central government organisations. So anything between those. Above those, you have to then put it out to formal tender, and it has to go in various websites and portals for organisation to bid on. So that's the process in terms of the tendering system. So there are one of the big concepts that require explanation is when you're looking at that value that you're looking at, that you're trying to determine, you have to look at the whole life cost of the equipment or the service or whatever it is that you're looking for. And that basically includes the upfront costs, okay, which can, it's the purchasing or the installation of it, the planning and all that kind of stuff that needs to go into it. And you have to add in the kind of operational and consumable costs and the maintenance costs, and you multiply it by the contract length, and then you add on any disposable costs. So that's how you work out the whole life cost. And it's important to look at that because different companies will give you quotations based on, you know, they may give you an example, again, anesthetic example, but if you had, we use kind of bronchoscopes, disposable bronchoscopes, which are fiber optic things that that you need a screen for. There's two components to it. There's a screen and then there's a scope. So one company might say, we'll give you the screens for free, but the scope costs £300 or £400 per unit. Another company will say, well, the screens cost £150, but the scopes are £100 per unit. Now, whether that, how it works for you as your organisation will depend on how often you use the scopes. If you're using it for emergencies and it's, you know, you might use 2 a year, then the costs will be different to if you're using it every day, you know, 5 or 6 times a day across the year. Okay, so again, it depends on how often you're using it and as to what the consumable costs will be. Okay. The other thing to factor in is the maintenance costs. You know, is it a managed system where if there's a new updated version, you can get a new updated version, or are they going to repair it? Are they going to replace them? Is there a warranty behind it? So that will also factor into it, because if you've got a large number, you know, if it breaks within the first year, how much is it going to cost to repair or replace it? Who's going to do it? How, you know, that kind of stuff needs to be factored in. And then the thing that we often forget is disposal costs. It's particularly at the end of its life, how easy it is to get rid of. Okay. So again, we're in the process of purchasing a robot for surgery. And actually, whilst the operational costs aren't that high, the planning and installation is taking months, because, you know, in order to install it, we have to reinforce the floor, because our theatre on the second floor, and so there's an installation process. There's we have to move a lot of stuff around, which then has knock-on costs. We have to plan about, you know, there's lots of meetings about moving, how to get it delivered and assembled, and the logistics behind that, and then the actual purchasing of the actual robot. Okay, so that's your upfront costs. You know, we're going to keep it for 10 years. How much are the consumables? How much? And that will depend on how many sessions how many operations we're going to perform with it, and then how, you know, there's so many parts to it. What happens if we break it? Because you have to move it in and out of theatre. What's going to happen if we break it? Are they going to replace it? How much is that going to cost? And you kind of give a, you know, approximate, you know, attrition rate essentially when you're doing that. So that's the whole life cost. You'll hear that a lot. And then there's something called value-based procurement. And what that means is you have to factor in, you know, you want to deliver good value for anything you buy. And you factor that in when you're thinking about what you're buying. So it's not just about the cost, it's about the value it delivers. An example of that may be, you know, you might buy, one of the things that's happened recently is how they do prostate operations has changed recently. So they used to do a prostate, a relatively straightforward prostate operation, but the patients often need to stay for a day or two. And more recently, there's a new gadget that comes out that costs a lot more. It costs a lot more to perform the prostate kind of resection, but it can be done as a day case. So then you factor in the fact that the patient satisfaction improves because it can be done as day case. Patient safety probably improves because it's actually safer in terms of complications, and you save some money because the patient goes home as a day case. And so that, if you add all that, if you factor all that financially in, it probably outweighs the cost, the upfront cost of the ongoing costs of the new machine. So you've got to weigh it up in terms of value-based procurement. So that's where the value occasion comes in, and improving quality is important there. So in practice, there are really 5 ways in which we purchase things as an NHS organisation. We can purchase things directly from individual suppliers, and that tends to be for kind of either quite niche specific stuff. It tends to be for new innovative stuff that the clinicians have been involved in producing and things like that. That can be directly from suppliers. About 70 to 80% of our consumables and our big high volume items are supplied through the NHS supply chain. And this is the supply chain. Whilst it used to be one organisation, it's now a concept that's overseen by a company that is owned by the Secretary of State for Health, and then which has a board, an advisory board, and then there's various towers, which I'll talk about in a second, and different companies run those different towers to organise and buy in different products, which then organisations there'll be a catalogue which you can buy from and you can order from directly from the supply chain. It means there's one price. NHS then tends to get better deals because you're bulk buying stuff. You get procurement collaboratives, so groups of organisations can group together to buy certain products and goods and services. So increasingly, it's becoming a service-orientated collaborative. And there are a number of procurement collaboratives around the country, including the London Procurement Partnership. There's Central England Procurement Collaborative, various things like that. Framework agreements and contracts I'll come to in a minute, and the government tenders and contracts tend to be from massive national programs like the NHS IT program or big purchases that are way beyond the tender limit and go for formal tendering for multinational companies generally. So, as I said, the NHS supply chain is 80% of English procurement, and bulk purchasing allows better prices. About in 2018, they kind of new operating model, which basically divided all the kind of things that the supply chain normally handles into 11 category towers, and they had people bidding for those category towers. So, for example, so things like a lot of the medical, ward-based consumables, infection control and wound care products are all, and the large diagnostic capital equipment are all procured by DHL on behalf of the NHS supply chain. And then sterile intervention equipment and associated consumables are procured by the collaborative procurement partnerships. Okay, so they basically put out for tender the kind of responsibility to buy these things on their behalf. Now, Office Solutions and Services is basically stationery, and that's done by Crown Commercial Services, which does it on behalf of the entire public sector essentially. So they do almost the entire public sector in terms of stationery purchasing. So they can buy it in bulk. So that's to give you a bit of an overview of how that works. Framework agreements are basically a pre-approved list. Normally, you put out a framework comes out, and it's normally for 4 years. And during that time, every so often they might open it up for new entries onto the framework agreement. But other than that, you tend to be on a framework agreement, and it tends to be for high value contracts. And the main purpose of it is to stop individual organizations having to go through lots of regulatory requirements, and you can buy off this framework agreement. They're pre-approved people that have already gone through a tendering process, and half the process has already been done, and so you can then choose from one of these other companies to do it. So it includes goods, but increasingly the framework agreements are used for capital works and for services, so overflow services, such as if you want to farm out, or you need to find somebody to do your cataract operations because your waiting list is too big and you haven't got capacity to do it. There's probably a framework agreement that will provide clinical services for that, and there'll be a list of companies that do that. I mean, the same thing for insourcing. There'll be a framework agreement for insourcing certain specialities. There'll be a framework agreement for outsourcing radiology reporting, things like that. So there tend to be high value contracts and a way of reducing regulatory requirements. And it tends to be for organizations to kind of get them themselves to outsource their surplus, what they can't do, what they haven't got capacity to, rather than directly commissioning services. So as a clinician, I've kind of put together a process of how I think, or a summary of how I think the process works. Okay. And it starts off with clinicians that want or need a product. So if you're either a clinician, you want something, or you're a non-clinician, you hear that your clinicians want something, or you discover there is a product that we need to enhance the quality of care that we deliver, you have to ask the question that, do we already have a like for like? Is there already something that is equivalent to that? This product you want may be better, but do we already have a equivalent product? And if there isn't one, then you can do a product evaluation, options appraisal, and then you may need a business case depending on the value of that and the process within your organization. Okay, so you can go down the evaluation, options appraisal, and then the business case is to solve the problem. And I'll talk about that when I do business cases later on. But that's the first step if there isn't a like for like. If there is a like for like, the question there is then, is there a contract in place? So if you're wanting to buy, say, new infusion pumps, or if you want to buy a new bit of kit, you've got to check that there isn't already a long-standing contract. Because if there is, unless you can show that this is different or there's a break clause in your contract, you're going to basically have to wait till the contract expires, and procurement can let you know of that. The next question is that if there isn't a contract in place, well, that's straightforward. You can contact procurement to initiate a trial. You can do an evaluation, and then you can initiate the switch. So that's how I see procurement. With a lot of procurement, there's a bit of a trade-off. You have to either, you've got cost, quality, ease, logistics, and things like that all play a part. Increasingly, environmental and the NHS net zero targets are built into the procurement process. So procurement over a certain amount has to have carbon reduction plans in place. You've got to show there is a working towards a net zero process, and there's a whole pathway that will so by 2030 most procurement processes have to show a net zero process when you're buying these goods. So that's my very quick overview, and rather than me talking about it for ages, I thought I'd open it up because everybody's procurement experiences will be different. As I said, I'm not an expert, and I am primarily filling in, and I didn't want to go into too much detail in terms of the procurement process, in terms of how the tenders work, the light touch regulation, and all that kind of stuff, because it is a relatively short session that we have. I only have another 10 minutes. So there was a question there. So the sterile gowns, not patient gowns, can choose to have their own style. They'll be even within the NHS supply chain. There'll be different variations of gowns that you can purchase, and you can tender out separately if you wish, but you might find it's more expensive, and then you have to justify that difference. So, for example, if the whole point of it is that they're bulk bought, if you were to choose that you want them a different type of style gown that's not part of the either collaborative or part of the supply chain, you're going to have to go and show why whatever you're choosing is better, both from a value point of view and potentially a cost point of view. So the argument needs to be much stronger. Whereas obviously, if you use a specific one that's off the supply chain, and you may be able to link in with the supplier to go, okay, can we just tailor it slightly differently? That might be okay. Okay, next. I hope that answers the question. If all of the hospitals in the area are using an external digital consent system, there is so there is a way of doing that. You can procure a specific system, and because again, it's to do with this would be on the framework exactly. So there'll be multiple. The e-procurement systems mean that there'll be multiple companies on the framework, and you can choose to have a particular digital consent provider. But it does depend on what your existing contracts suggest. So yeah, so essentially, I think that for digital consent and e-procurement for IT, there are lots of framework agreements in there, and you would just choose the one that would be similar to your ICB. So we use my pre-op for our we use Concentric for our digital consent, and I know we did an options appraisal, so we actually looked at multiple different providers of digital consent, but we chose one that was actually being used nearby as well. So it depends on making sure that you not only the linking in across the others to other organisations in the ICB will be one part of your criteria, but you probably still have to make sure it's fit for your purposes as well. I'll come back to you, Madeline, on a single tender waiver. If that's all right. I think we can probably have a 5-minute just a screen break to kind of stretch your legs, because we've not had one since lunchtime, and also it allows me to get a drink, because I'm not doing the next session, am I? No. Do we have, is Paula here? Then we can continue straight on.
I am here, but I mean, happy for a 5-minute break while I just get my presentation loaded up.
Perfect. So shall we have a quick 5-minute break if nobody has any questions? Madeline, I'll write something in the chat, because it's easier to write it down and try and explain it. So yeah, a 5-minute break, and then we'll come back with Paula, who's going to be talking about clinical coding. Is that all right, Paula?
Yeah, that's fine.
Great. Shall we kick off again? So welcome back. I'd like to welcome Paula Brereton, who's the Head of Clinical Coding and Service Development at Warrington Halton Teaching Hospitals, who's going to demystify clinical coding for you.
I'm going to try anyway. Thanks for inviting me along to speak today. A little bit of introduction about me. I've been in the NHS for 38 years, thereabout. Started in operating theatre and main theatres, and then went to neuro theatres, about 9 years in total. I've been an information analyst, a systems manager in procurement. I was an IT project manager in primary care, looking after child health, sexual health, prison health. Actually, when I tell people I've been in prison, I don't think they believe me. Managed IT projects for 23 GP practices. Then as a project manager in secondary care, relocating services as part of a new hospital build, also putting a theatre system in. And then I moved as a clinical coding manager, and then in the last 7 years, head of coding and service development here at Warrington. So hopefully today I'm going to bring to you some demystifying of clinical coding. So first of all, what is clinical coding? Well, basically, here's the definition. Clinical coding is the translation of medical terminology as it's written by the clinician to describe a patient's complaint, problem, diagnosis, treatment, or reason for seeking medical attention. And that's translated into a coded format, which is nationally and internationally recognised. I'm sure you've heard about the World Health Organization, or the WHO as they're commonly called. Well, this is where we get our diagnosis classification, which is ICD-10. And we have OPCS for our procedures and our interventions. Now, the most important thing from this slide that I'd like you to take away is the text that is in red, and I want you to remember this. So let's talk about clinical coders for a minute. And what are clinical coders? Well, basically, they're ordinary, everyday people, but also the storytellers and the detectives. They need to be a detective to tell a story. They're also terminology, anatomy and physiology gurus, the scholars in the art of decipher and scribble, and quite often, but not all the time, the geeky nerds. But what clinical coders work very, very hard. But what clinical coders are not, they are not telepathic. And again, I will refer to this telepathy a bit later on in the presentation. So recruiting into clinical coding is very, very difficult. And in fact, we actually are unable to recruit anybody who's trained. So we have to train our staff from scratch, and it takes a minimum of 3 years to get them to a stand where they can just pass their exams, and then they have to go on and get their kind of experience. So trying to entice people into the service has been very difficult. So I've changed tack to try and entice people into the service, and this will give you an idea. I call it a day in the life of a clinical coder. And what I tell them in the advert is that you work at your local hospital, where your team record information about every patient who is admitted to your hospital, investigating all aspects of the journey, aspects from the start to the finish. You confidentially tell the inpatient story in a coded format to support quality patient care and ensure correct reimbursement for the care is given. You begin by reviewing the stay of an elderly woman who's had a hip operation 2 days ago. And from a digital and paper medical notes, you identify which ward she was on before her surgery, the details of a diagnosis, any operation or treatments that she's received, and any comorbidities that she may have. And then you use the special alphanumeric code system, i.e. the ICD-10 and the OPCS that you have been trained in, and you assign the correct codes before entering the coding on the computer system. These records can be understood throughout the NHS and are used to plan for future patient care and also for reimbursement. You're excited to code your next patient journey as you are multi-skilled, and you code a wide range of specialties, which include but not limited to general surgery, ophthalmology, gynecology, maternity, trauma orthopedics, and ENT. You love the detective element of your job, investigating diagnosis and procedures to ensure that you have a full understanding before coding and learning about healthcare and new treatments, which means your work is always interesting. You accept that there is ongoing learning and updating of your skills, and although the work is challenging at times, you gain a great deal of satisfaction from doing a brilliant job and supporting patient care in a non-patient facing way. Now, obviously, it's much more complicated than this, but at least it's enough generally to whet the appetite of potential candidates who want to find out more. But what I don't share, and because I don't want to scare anyone off basically, is that there are challenges, and there are many, many challenges. One of them being badly written documentation. So here's an example of documentation, and it isn't the best. So the patient may well have an issue with their lung, but it's highly unlikely that it would be lung nephrosis, as nephrosis relates to the kidney. Now, this next example, if anyone can work out what is wrong with this patient, please tell me, because I'd be very grateful. Put it in the chat. Another challenge that we have is conflicting documentation. So quite often there is conflicting documentation in the patient notes, and it makes it very difficult to know what is right and what is wrong. So, for example, we've recently seen a patient, and in their current spell of care, we've seen that it is documented as metastatic neck cancer. However, with the clinical coders doing a diligent job, they have noticed that in previous spells of care, the patient was documented as having secondary cancer of the neck. Now, the rules around clinical coding mean that we cannot change the coding because we can only code what is documented in each spell of care. Copy and paste. Because some clinical systems, I'm putting it politely, are less user-friendly than others, time-saving processes can creep in, and copy and paste is one of those processes. However, it is fraught with many issues, including incorrect terminology, which is copy and pasted. Resolved issues are copy and pasted later on in the stay. So, for example, somebody may come in with delirium and then it is resolved, but because of copy and pasting, it looks like the patient may be delirious again. And it also elongates the clinical documentation with repeated information. So for clinical coders, it takes a lot longer because they read the same information over and over again, but they have to read it in case there is something that they may miss. And again, in clinical audit, clinicians and also kind of reviewing a patient will be reading this copy and pasted document, which will take a lot more longer to read the patient notes. Abbreviations. Now, we can have multiple abbreviations for the same, or multiple meanings for the same abbreviation. And this can make it difficult to establish which is the correct one. So you can see there that we've got, quite a few common ones, with CHD having 3 different kind of abbreviation or descriptions going with that abbreviation. And again, this can make it difficult for the clinical coders to know exactly what the clinician is referring to. And also sometimes clinicians make up their own abbreviations. I kid you not. Spelling mistakes. So you've got to love these spelling mistakes. Sometimes spelling mistakes can make it quite difficult for the reader, but also it can be quite amusing. So in this example here, we can see that this patient had a good ROM to shoulder. Had no bursting and had bursting to the left side of the head and no buoy tenderness over the head. So I think we can read between the lines there and see that they're talking about bruising and body tenderness. But unfortunately, things like this mean that the coders, if there was something significant there and the actual documentation wasn't correct, they couldn't code that condition, and that can have an impact on income and also quality as well. Here's another example, and these are actual examples, and I've not made them up. This is what we've seen in some of the notes there. Again, swollen, and both swollen legs as well. And again, this one, and again, it is quite funny because this patient has a fatty liver, but we know that actually says a fatty liver, but unfortunately, we wouldn't be able to code that because it doesn't say the right thing. And this other patient has got a fatty liver cyst. So can be quite amusing, but there are serious, implications of not being able to code that. Illegible handwriting, and this has to be high on the list of the most challenging for clinical coders, and especially when they're having to read all day long. Take a look at this operation note. Now, that's not easy to read. And if it's not enough for you and tough enough, then look at page 2. It doesn't get any better. And again, this is a daily occurrence. So translating test results, despite what some people may think, clinical coders are not doctors. So they can't actually make a diagnosis, well, not officially anyway. So here's some test results, and in an example of patient test results where there's multiple asterisks next to the test results. And some of what that means is basically that the test results is out of the range of the normal range, and that could indicate an actual condition for a patient, but without documenting it, clinical coders cannot then code that condition because they're not doctors, so they can't translate those results into a diagnosis. So the first one you can see there is that the HB is outside the normal range. Now that patient is queer, we're thinking the patient has anemia, but without it being documented, we can't code that. The next one down that you can see, it's not documented as low sodium, although that result indicates that is low sodium. And then the final one there, quite a serious one that has an impact here, which is CKD3. It has an impact on mortality. So again, if you're looking at the actual scores for mortality and the risk indicators, that particular condition has a risk score of 10, which is quite high when you look at the Charlson Index comorbidities. Broad terms is another kind of issue, and we ask for is for clinicians to be specific. So documented by the clinician, an example is excision of a sigmoid colon. But if you look in these OPCS codes, there are multiple different ways of excising sigmoid colon. And again, it's around about trying to be specific and documenting the patient's condition so that we can accurately reflect it in the coding. And again, that can have an impact on mortality, on any kind of quality indicators, on outcomes measurement, which I'll go into in a little bit more detail, and also potentially on income. And then finally, it is simple, but it's true. If it isn't documented, then it didn't happen. If a patient's being treated for a condition, or for example, is on inhalers for asthma, then without the asthma being documented, they simply don't have asthma for the coders to be able to code. And again, if a patient's had a catheter inserted, but it's not documented, well, then it just didn't happen. So why does it matter? Well, basically, it matters because clinical coded data feeds many different beasts. And you can see here some examples: clinical governance, case mix planning, you've got your financial flows with your HRGs, your national tariff payment system, benchmarking is a biggie. So it's very important and it needs to be accurate. And it matters because the clinically coded data that underpins and drives mortality. So you may or may not have heard of your HEAD report, which is the hospital episode data reports, your HSMR mortality and your SHIMI. Also clinical audit, outcome measurements. So again, are we measuring the accurate outcome, conditions and the outcomes from those conditions if we haven't documented it right and coded it correctly? The Care Quality Commission for Innovation, looking at sepsis and heart failure, the themes change each year. But again, if it's not documented appropriately and we can't code it accurately, then that's going to have an impact. And model hospital, again, this is looking at depth of coding and clinical performance. I think one that is quite popular at the moment is GIRF, compare and trust clinical performance. The clinical coded data will underpin the GIRF measures. And finance, again, looking at contract negotiations, income, the patient level costing, and also activity monitoring. The consequences of not getting it right can come back to bite us because it's used for benchmarking data. and the benchmarking data for performance is going to be incorrect. So your 18 weeks, perhaps, you know, we're looking to see how many patients who are on maybe a trauma and orthopedic list for a specific procedure. If we're not getting that documented and coded right, then it's going to have an impact on that. And also the biggie at the moment is the elective recovery. Theatre utilisation. So you maybe think, well, what's that got to do, you know, with getting coding right and theatre utilisation? Well, sometimes, you know, and quite often particularly GERT will look and say, well, you've done 3 procedures in this trust in an afternoon, yet the trust down the road have done 4 or 5. If we're not documenting the complexity of procedures, and complexity can take longer than less complex procedures, then we're not actually representing the true activity that's gone on in that theatre. So the utilisation may look low if we're not, you know, capturing that information correctly. Mortality, again, something that I have mentioned, but if we don't get the data right, the consequences is that we could have more observed deaths than what we were actually expecting to see. And also on signs and symptoms, if we're not documenting actual patient conditions, and we're just putting signs and symptoms down, then it could look like it's poor care. Hello? Sorry, someone came in on that. Sequence. So again, potential loss of income, because with these care quality for innovation is a potential loss of income if it's incorrectly coded, if we're not hitting the targets that we should be hitting. And GERT is something that I mentioned before as well, which is clinical performance. Again, we could be incorrectly compared against, you know, nationally or locally, the performance of the clinical performance of clinicians. It's also potentially missed opportunities for improvement, and also missed opportunities to shine as well, to show how well we're doing with specific areas if we're not getting the coding right. Length of stay is quite a topical issue that hits a lot of people. So length of stay can be impacted as well. So we have patients who maybe have more complex procedures or complex conditions that keep them in hospital longer, but they're not documented. Then it looks like the average length of stay is skewed, basically, if the complexities are not documented and coded. And also sometimes these complexities and the comorbidities could extend the length of stay, and it's not being captured. And then the cost of care, which is reimbursement. Now, potentially, we could lose income if we are putting all the resources into doing multiple tests for different conditions, or somebody has maybe got dementia and things like that, where we need maybe a bit more, you know, one-to-one nursing with them. We're not capturing those costs by not documenting it. So potentially it could cost us more to look after those patients, and we're not getting that income back into us. And then finally, outcomes measurement as well is, you know, we want to make sure that we are comparing accurately against procedures, and that, you know, we're not comparing apples and pears. So now it's time to get interactive, and it's your turn to have a go at being a clinical coder. So what you're going to need is a paper, pen, some good eyesight, and a sense of humour. And I think we're going to use the chat box for you to get involved in this. So hopefully everybody has these things ready. What you see in front of you is an operation note. And I appreciate it's not very easy to read. So welcome to the world of clinical coding. So what I'd like you to do is to read through this documentation and write down what you think the procedure was for this patient. I'll give you a couple of minutes just to have a look through. And I'll give you a tip. Ensure that you don't miss anything. If I can get some thumbs up to show that you've written down, that would be helpful. There's one, if you're there. Okay, bear in mind time, I'm going to move on. Okay, so here's some procedure codes, and these are actual OPCS codes. So what I'd like you to do now, select which you think are correct and write just the code, not the description, next to the procedure that you've documented. And again, if I can get some thumbs up once you've done that. The thumb coming up. Yep. Cool. Okay. So now it's time to share. So can you just post in the chat box what you got? Just the codes. Two, four. Great. Okay. Thank you for that. So this is what you should have got. So we first of all start off with an anti-reflux wound application using an abdominal approach, which is a G243. So well done to people who got that. And then that's immediately followed by the Y code, which is saying that it was a laparoscopic approach to the abdominal cavity. But then also there was a repair of the esophageal hiatus using the abdominal approach. And again, that was a laparoscopic approach. So what you actually didn't see, or perhaps didn't see in this, if you look very closely, can you see that I've highlighted something in yellow now? So that word there, can anyone put in the chat box, tell me, or even speak probably quicker and say what you think that word is and what it means? I know it's difficult to read. Brill, well done. Yeah. Does anybody know what it means? Okay, so what that actually means, Krill, is that's the hiatus hernia, and what's happened is that we've done the laparoscopic fundus application, but also we've done a repair as well of that of the hiatus hernia. Now, it's important to know that, and it's important to get that right, because as you saw, it did change how we coded it. There was 2 procedures. Now, just think about the consequences of that and what I've said so far. Other than financial, we're looking at outcomes measurement. So if we are looking to see, well, how did some of our patients, we had 20 patients, 30 patients who had a fund application, how well did they do after that procedure? If we're only measuring patients on that, but however, 1 or 2 or 3 patients have had a hernia repair as well, and we haven't documented it appropriately or captured it and coded it, then we're not comparing apples and apples. Also, it could potentially be that that patient who's had 2 procedures may stay in longer, or the theatre utilisation, they were in longer because there was 2 procedures being done and not just 1. So that's why it's important to get that right. And the difference financially is without accrual, you can see the range there on tariff is between 3,500 to 7,800. The difference being comorbidities that would take that off for complexity. And then with the accrual being documented and coded, there is quite a significant difference there. Your minimum is 5,000 up to 10. So I hope you found that really interesting. So basically, instead of getting a beautiful and appetizing edible hedgehog cake like this, what you end up with is a bit of roadkill. Obviously, true clinical coding is a lot more complex than that, but hopefully that's been a little bit of fun as well as educational for you. Now, I couldn't finish without mentioning comorbidities. We've touched on it a little bit, but they're incredibly important because they tell the story and the complete story of the patient. So here's an example of how adding comorbidities can increase the income. On the second one there's 6 times, and then on the third one it's gone up by 13 times. But what's important there on the bottom as well, you see that mortality risk weighting is 42. So again, I'll give you another example in a minute of why it's really important to get this right. And here we are, mortality impact. So, these are 2 patients, and this is fabricated, but it does happen. 2 patients who both got a fractured neck of femur, and they both had exactly the same procedure, and both in for exactly the same length of time, 5 days. So hopefully by now you're thinking, right, okay, we're going to be measured on this. And one has been discharged home, and the other patient has been discharged to the mortuary, sadly. But what is the difference? We're going to potentially get the same income because, there's if there was no comorbidities documented. But what you can see here is that the ones in red are all those comorbidities that have some form of a risk of death associated to it. So we don't have the benefit of people who look at the figures and who collate all our mortality, and they don't have the patient records in front of them. All they can go off is the data. So if they see 2 patients with a fractured nerve, one went home and one didn't in the same time, why did we look after one really well and we didn't look after the other? Well, this tells the story that actually one had no comorbidities and that's why they went home, but the other one was very poorly anyway. Am I back in the room?
Yeah, you're back now. We lost you for a
Thank
second there.
Sorry, I don't know what happened there. Okay, so again, talking about that, comparing apples and pears there. So love your clinical coders because in a way they're your biographers. Make sure that they have all the facts to tell the story and the right story of the care that you give to your patients. And finally, your takeaways. So remember the skills of the clinical coders. If it's not documented, then it didn't happen. Remember that telepathy. The clinical coders don't have that, so they need to see it documented to be able to capture it. And what was that very important thing that I asked you to remember at the beginning? As written by the clinician. And it's in red here because I'm a Liverpool fan, but also it's a key to accuracy as well, so I can make it stand out. And comorbidities are incredibly important. And love your clinical coders because they do write the story of your patient care. Any questions? I've done this in blue for any Evertonians in the room, but don't tell me, Dad.
Hi, Paula, can you hear me?
I can hear you, yeah, can you hear me?
Yeah. Yes, I can. I work in the emergency department. I'm an ED consultant. This is, thank you for that presentation. With a lot of EPRs coming in, since we started our EPR, we've been coding all our patients that attend the emergency department, and there are many benefits of coding, as you clearly explained. There's also that is the information that goes back to the GP, and with our immediate discharge summary that is electronically sent to the GP. But there are two questions I've got. One is why is it that some codes are not there when it comes to the acute care setting? So I've spoken to a lot of EDs around the country, and they struggle with a particular coding system called Snowman, which don't have a lot of codes because your ultimate diagnosis is often not made in the emergency department because that patient goes on to the ward. And a simple example is a rectal bleed. They might have hemorrhoids, they might have polyps, but that won't be made. A definitive diagnosis won't be made till they get to the ward. So the codes are often diagnosis based as opposed to symptom based, and hence a lot of codes are end up being inaccurate when it's finally coded in the emergency department. So, is the NHS or at least the acute care setting, do you know why there isn't a standard of coding? My second question is which codes get payment? So, for example, if I have a patient who's come in following a road traffic collision and it's a major trauma, so they might have an intracerebral bleed, they might have fractured ribs, they might have ruptured spleen. So those are, and many other injuries. So I would have treated the patient with maybe blood transfusion, a chest drain put in. I may have also done a CT scan and also a few X-rays. So if I put all those codes in at the end of that episode for that patient, do all those elements get payment, or is it the highest tariff that gets payment?
Okay, so the first question is around SNOMED, and that is for A&E attendances, and that's not my world. My world is OPCS and ICD-10 for a patient that is admitted. So the minute that, even from a decision to admit, so they may still be in A&E, and we say, right, decision to admit, and then we're waiting a bed. From that minute on, the class is an inpatient, and we would capture all that code and use an ICD-10, which is more specific than your SNOMED code. And there's more granularity around it. And there's a lot more codes that you will put in for patients once they're an inpatient. So the SNOMED is not our world. It's not something that we do or responsible for. And I get what you're saying about signs and symptoms. You don't always know in those early kind of hours or day or whatever exactly what's wrong with the patient. And it's something that we try to work on because we work on episodes of care as well. So a spell of care can have multiple consultant episodes. So if we don't transfer or have incorrect episodes of care, we're more likely to get a diagnosis in the first episode, potentially the second episode, which then contributes to your mortality. So I don't know if that's answered your question around the coding for SNOMED.
That's yeah. Good. Thank you.
And then the second one, which is the codes. So yeah, I've been asked this quite a lot in the past. So what happens with healthcare resource groups is we capture as much information as we can, is documented, and all of that coding will be put into, well, we use an encoder that then feeds into the patient record. And then the grouper system, the national grouper, will take all of that information and it will look at the different episodes of care, and it will look at the most resource intensive as a group, and then the payment will go for that. You won't get paid, for a cardiology and a TNO and a urology all together, or a general medicine. It looks at the most resource intensive, and you will get the income for that.
So for the highest resource required, will be paid as opposed to the least resource?
Yeah, it's documentation, basically. Everything that you do to the patient, if you document it, like I showed in that example with the comorbidities, how that can then, take the HRD. You can start off with your basic one, but then you get your levels of complexity in your comorbidities by adding all of that information. And there's the algorithm is immense to try and get your head around. I've tried to try and look at it. I can look at maybe one area, but trying to work it out, there's thousands of them. If you add this in, if you add that, there's so many different things that contribute to a HRG. So the message I always say is document everything. If you did it, if it happens, if they've got it, document it. Your clinical coders, skills and expertise will pick that up, and they will then represent the care that you've given to that patient in their coded format, which then will be accurately reimbursed by the HRG.
Thanks, Paula. Thank you.
Next question.
I was actually going to come in, Paula, on Biju's question. It's to do with the emergency care data set. So A&E attendances are recorded into the emergency care data set. And so most EPRs that form, so SNOMED is vast. SNOMED covers every diagnosis possible, really. And it's just a terminology that we use as clinicians to enter it onto a system, and it gets translated. So we can use SNOMED in our systems as inpatients, and it will get translated into coding terminology by the coders. The issue that you guys have in A&E or ED is that because of the emergency care data set is limited, the SNOMED, and there's no point putting in any codes that don't go into the emergency care data set. It's the emergency care data set that's limited. So it's the fact that your EPRs have restricted your SNOMED capabilities to conform with the emergency care data set, because otherwise it doesn't get captured at all anyway. It's to do with that aspect rather than SNOMED itself, or it's so it's the fact that when you type in something into, we've had the same issue in our hospital. So when you type in something into your EPR and you try and type in something that doesn't falls outside of the emergency care dataset codes, it won't let you. It doesn't. If there isn't anything that marries across to the emergency care dataset, it won't let you put it in. That's the ultimate issue.
And there's no change coming for the ECDS.
There's constantly change coming to the ECDS, and I think it will increase as they increase doing SDEX, the same day emergency care processes, because a lot of those are going to become part of the emergency care data set rather than being coded as inpatients. They're going to have to increase it, but it will take time.
Yeah, type 5 will be coming out. We're an early adopter of type 5.
Yeah.
And then there's type 6 then, you know, when they're coming back from SDEC. So yeah.
So as they increase the pool of patients you're dealing with, the pool of SNOMED codes will probably be opened up.
Thank you.
Okay.
Any other questions? Doesn't seem to be. Stunned into silence. I've got one question, and a show of thumbs. Would anybody like to come and train to be a clinical coder for me? If there was a thumbs down, I would expect to see lots of them, because that's the often response I get.
Well, thank you, Mo. Thank you very much, Paula. It was really interesting, and really interactive. So I enjoyed that too.
Thank you.
So we're supposed to have another screen break, but I'm gonna, in essence of time, I think what we'll do is we'll have a little bit of a stretch for 2-3 minutes, just so you can stand up and stretch your legs, and then we'll go straight into Introduction to Primary Care Finance with Andrew Roberts, who's a primary care business partner for the Leicestershire and Rutland ICB. So, Andrew, are you happy waiting a couple of minutes before kicking off?
Sure, yeah, that's fine. Thanks, okay.
Brilliant.
We start at 3. Straight.
Yeah, if you start, maybe if you start a couple of minutes after 3, give it 5 minutes, and then allows people. We had a bit of a coffee break before, a 5-minute break before the last talk, and another 5-minute break now means that people can do what they need to do, and then.
Okay, that's fine.
Great, thank you.
Thank you. Hi, everybody. I'll make it about 2 or 3 minutes past 3. So if we can, I'll kick off and go through the introduction to funding in general practice. My name's Andrew Roberts. I work for Leicester, Leicestershire and Rutland ICB and have done, well, I've been in the NHS for 33 years, always in the commissioning side, so the Health Authority, and now finished with the ICB. We were 3 former CCGs covering 1.2 million patients. LLR ICB has a budget for commissioning services of 2.1 billion for this year, and we cover 130 practices across LLR. So I'm assuming that everybody can see my slide presentation. So if you can speak up if you can't, but I'll carry on. So today I'm going to go through a number of funding streams for general practice, and they're listed there. We've got a basic slide on each one of those, more or less, but I'll go straight into, because conscious of time, we've only got half an hour, we'll just go into core contract. So GPs are paid through what we call a core contract. There are 3 types of contracts out there. The vast majority of practices have a general medical services contract. This is list-based price based on what we call the Carhill formula. It was introduced back in 2004, and it's based on a weighted capitation basis. So the Carhill formula takes into account things like patient demographics, so their age, sex, market forces factor of the practice list, patient morbidity and mortality, care home residents, nursing home residents, rurality, and also the turnover rates for lists. So how quickly the turnover patients leave and join the practice. There's a list size adjustment on a quarterly basis. So each quarter from 1st of April onwards, there is a list size adjustment, and then the practice payment will adjust to reflect the quarterly list, weighted list. It's paid at £102.28 this year for the per weighted patient. And there are a couple of items that are that practices can opt out of. The main one is out of hours. So the vast majority of practices do not provide an out of hours service. And by opting out, they basically give up 4.75% of the 102.28. The commissioner then has to provide an out of hours service. The other item that they can opt out of is minor surgery, and obviously their opt-out percentage is significantly less than the out of hours. There are a couple of other types of contract, personal medical services, which generally is more of a quality-based service and it's locally agreed, more flexible than the national GMS service, and approximately 26% of practices hold a personal medical services contract. And then there's the alternative provider of medical services contracts. This gives even greater flexibility and it is open to other providers. So we've got sort of private and third-party bodies that provide primary care services through an APMS contract. And it allows the commissioners to purchase a service for specific groups of patients. So in Leicestershire, we've got a homeless APMS and an asylum seeker assist service that looks after asylum seekers across LLR. So those are the types of contracts. The contracts are all to provide essential services. So mandatory services for registered patients, which is the identification and management of illness, providing health advice and referral to other services, and covers the period from 8 AM to 6:30 PM Monday to Friday, excluding bank holidays. So that's the in-hours service. The practices should be open all the time during those periods. One of the next biggest areas of spend is in relation to the quality and outcomes framework. This was introduced with a new contract back in 2004, and it's an incentive-based scheme, quality-based, and it's based on number of points. Each year, the number of points are amended or can be changed at any point to reflect, obviously, the national priorities at the time. This year, the practices have got 635 points available. 554 are conditional and 81 protected. A value per point is worth 213.43 for 23-24. And that's based on an average practice list size of 9,639. So how it works is each point is worth £213 for that average practice. If the practice list size is twice 9,639, what's that, about 19,000, they get twice the 213.43 per point. It's also adjusted for prevalence, etc. So that's how the quality and outcomes framework works. It is a significant element of resource for practices. They get paid a 12th of 70% of last year's achievement throughout the financial year, leaving approximately 30% to be paid once the final figures have been worked out. So at the end of March, they all declare their positions in relation to their scores. There's a bit of verification work that happens, and then this month, so June 23, we'll be paying the achievement payment for 22-23, which, like I say, accounts for about 30% of their QOF income. And then obviously we're now paying an aspiration for 23-24. The final payment of that will be paid in June 24. Sorry. There are a number of clinical domains. So these include vaccinims, atrial fibrillation, diabetes, asthma and mental health. And there are also some public health domains as well as quality improvement areas that are included in the quality and outcomes framework. So as I say, that's quite a sizable element of practice income from that area, from that funding stream. The next part of the contract is enhanced services. So these are services that are linked to the core contract, so the GMS, APMS or PMS contracts, and they cover 4 sort of areas. So there's the learning disability health check. So patients with a learning disability should have an annual health check. Practices get a payment for each one of those health checks. There's also a minor surgery enhanced service that pays practices for providing minor surgery. The deregistered patients is effectively patients that have been removed from practices list. So there is an enhanced service to provide that service to those patients. We've got an APMS practice that provides services to the deregistered patients, and I think there's about 90 patients across LLR that are on that list at the moment. They have to see clinicians either face-to-face or online with that particular practice concerned, and obviously treat it like their own practice. And then also there's a PCN participation payment, which is also a directed enhanced service. This is to provide all practices with £1.76.1 per weighted patient for actually participating in their primary care networks. So that's a bit of an incentive for them to get involved in PCN work. And I'll come on to PCN in a minute. So The next area is premises funding. So each practice is obviously located in a GP premises. Those premises are either owner occupied or rented from various bodies, including the NHS Property Services or community health partnerships. Funding for those from the ICB comes in the form of a number of streams. So for all those properties that are owned by the partners, we pay a notional rent. That notional rent value is based on the district valuer's assessment of the property, sort of market rent for that sort of property, and their condition, etc., and location. We then pay that to the practice on a monthly basis, and that's generally reviewed on a 3-yearly rolling programme. So the amounts will change every 3 years. We also pay for owner-occupied, for rental or leased properties, the actual rent, and again that is based on the current market rent for the sites, assessed by the district valuer. So the practice will receive a monthly payment to cover their actual rent. And then for the properties that are covered by NHS Property Services or community health partnerships, which for LLR covers about 7 or 8 of the former Liftco buildings. So a lot of investment went into the practices, into primary care sites back in the noughties, 0 to 10s, and they've got primary care premises included in them. CHP are the landlords for those, and we pay the practices for the cost of that the CHP charge them for their rent for covering the buildings. In addition to the rent, they also practices claim for their rates. So the annual non-domestic rates bill from their local authority, that's reimbursable by the ICB. They also claim for water rates, clinical waste as well. So clinical waste is charged to the ICB ultimately, as are the water rates. So that's quite a significant amount of income that's reimbursed to the practices to run primary care. Community-based services are locally commissioned services to meet our or local patient need. These are separate agreements and are either commissioned on a price per activity or a block arrangement. So a block arrangement would be, we pay you 10,000 to treat all the patients, for example, with this condition, and the risk sort of lies with the practice. Cost per activity, they would generally claim, or we'd pull off the activity off the clinical system in order to work out what the payment would be for the quarter. There's some examples there of community-based services, so near patient testing, secondary care bloods. The biggest one in LLR is INR monitoring for warfarin patients, and also for direct oral anticoagulant patients as well. We pay about 2.8 million to providers to monitor warfarin patients and do an annual check on or quality check on the DOAC patients. So that's quite a significant resource as well for practices. We have a number of sites that provide a CBS for their travelling family communities. We've got 1 or 2 sites within LLR that cover travelling families, and the local practice will be paid extra to support that cohort of patients. As I mentioned earlier, there's the primary care networks, and these were introduced back in 2019, and they are a group of general practices that covering a specific area typically 30 to 50,000, although in LLR we have one that's over 100,000 patients. All practices receive a participation payment, as I said earlier, and PCNs receive a number of funding streams that I've put on that slide there that detail for various elements of the network. The biggest one is the Enhanced Access Scheme. So £7.50, 7.8 pence per adjusted patient to provide an enhanced access service. So this covers the period from closure in the evening till about 8 p.m. and Saturdays from 9 till 5:30 p.m. For an extra access for patients. So that's quite a significant level of income for PCNs and quite a responsibility for them to provide. There's also the Investment and Impact Fund, which is similar to the Quality and Outcomes Framework. It's a quality incentive scheme, but this time for the primary care network. So the group of practices working together are incentivised to meet various targets. The major change that came about with the introduction of the primary care networks was the Additional Roles Reimbursement Scheme, or ARS. This invested significant amount of resource in PCNs. Our budget in LLR this year is around 25 million to reimburse practices for a number of clinical roles. I've put two down there. Social prescribing link workers and community pharmacists were the first two to be introduced back in July 29. But this next slide details the rates and the roles that are now available for reimbursing to PCNs. So I think overall across the country there's about 26,000 additional roles being claimed for. And as you can see from the slide, we've got roles of various bands. For first contact physios, for example, band 7 to 8A. And there's a couple of new ones recently. There's the general practice assistant that was introduced in October 22, as well as the digital and transformation lead at a band 8A. These are the rates for national and inner and outer London, just for information. The adult mental health practitioner and children's and young people's mental health practitioner, they're generally shared role between the PCN and the local provider of mental health on a 50-50 split. So they're generally employed by the local partnership trust. So as I say, that's quite an element of our resource going to PCNs to cover those roles. The Impact and Investment Fund, as I say, is a quality scheme. So this year's 262 points available. Each point's worth £198. It is both qualitative and quantitative. And there you can see some examples of the different elements of the IIF. Obviously, practices need to work together in order to achieve that. So it gives them a bit of incentive for closer working. So yeah, that's the IIF. And then just finally, there's a few areas of other funding streams that practices receive. So locum cover, practices can claim for a contribution towards maternity, paternity, sickness, or if a GP is suspended, the ICB will pay set rates per week, depending on the statement of financial entitlements, which is sort of our Bible for working out what practices are due to claim or what they can claim. And that rate, it changes every year. And that contributes towards the cover of those sessions. They can then purchase locums to cover the sessions. It doesn't go anywhere near covering the cost of the session, but it is significant. It's like probably about £1,300 roughly about a session. Syringes and needles, practices are provided with syringes and needles. The ICB pays for those. All the GPIT that's in the practice, well, a significant amount of it is provided by the ICB. So, you know, the booking systems, the systems on the clinical systems, the IT hardware itself is provided by the ICB. We've got a provider who covers all of our practices and provides a support service as well. So there's a help desk that practices can access. There's a rolling replacement program as well that we have in LLR that provides kit after a number of years, replaces kit after a number of years to ensure that it's not, it continues to provide the job. They practices also receive prescribing fees and the drug costs for anything that they've purchased at the practice. They can also claim for reimbursement of their annual Care Quality Commission fees from the ICB, so we have a budget for that. And then there's a couple of areas, so not all the funding comes from the ICB. NHSE and NHSE as it is now, commission services, so they purchase the immunisation and vaccination programmes, and they also support the trainee GPs. So a number of practices are classed as training practices, and they will get funding for providing that service. And then there's the public health services that are provided for local authorities that cover contraceptive services, smoking cessation, and drugs misuse. So those are sort of a quick run through of some of the other funding streams. Just of time. So have you got any questions? Bear with me and I'll just close my screen. So that was a very quick run through. I'm sorry about that, but it just gives you an oversight as to what how primary care is funded by the ICB and the NHSE and local authorities. Do we have any questions?
Stunned silence, Andrew.
Blinded by science.
We'll give it another minute, see if anybody's typing rapidly.
Yeah, I've just got the chat open.
Okay, there's a question there, Andrew. Do the ICBs impose penalties if there's a bad rating or issues related to that?
Not well. They would issue a contract notice if there was a breach of contract. If the rating, if the CQC rated the practice, well, the CQC effectively can close the practice down. So we have got one or two instances where the practice has failed CQC registration. The practice can't then obviously provide services. So the ICB then has to pretty quick provide a caretaking service. So over a couple of days, we generally run a procurement service exercise to find an alternative provider to provide caretaking services to those patients, and the caretaker generally continues for a period of time while the ICB goes through a process of a proper procurement process to re-procure the service. Caretaking generally costs an awful lot of money because, you know, we're covering a patient list at short notice. There's generally a lot of work to do on that patient list. So, you know, might have letters that need, or a backlog of work that needs dealing with, you know, depending on what the CQC have identified. And then we usually find ourselves in a situation where, you know, we have to fund the practice caretaker to deal with all those issues in order to get it to a suitable point to be able to re-procure, really. Yeah, so we had a situation sort of 18 months ago where a practice lost its registration, and we went through precisely that process. Does that answer the question? But if there's a minor breach, then the ICB would do a contract breach and obviously work closely with the practice. We don't generally withhold funds from them.
Thanks, Andrew. I guess there's a similar process if a practice fails for other reasons.
Yeah.
So, and one final question: do personally administered medicines by GPs get refunded by the Business Services Authority or ICB?
Yes, that's part of the prescribing drugs costs. So the practices submit a claim to the PPA up in Newcastle on a monthly basis. Anything that's personally administered at practice would get refunded to the practices. We have a budget for that. We've also got a drugs budget that covers the cost of anything that's prescribed by the practice and dispensed wherever. So we sort of monitor the budget we have a budget for each practice, and we monitor their spend against that. We have a team, a meds optimization team, that are reviewing and monitoring drugs prescribing spend and doing, you know, switches and things like that, getting practices to change patients' drugs in order to make savings. We have got quite a significant savings target this year, as you can imagine, with a lot of the other ICBs. So prescribing is quite a big area where we can make some savings by doing switches and changing habits, really.
Great. Thank you very much, Andrew. As always, an excellent talk. And we're moving swiftly on to understanding budgets and spreadsheets. A fascinating topic that I think is always very popular. So Louise Lowry, who's Director of Operational Finance at Yorkshire and Humber, NHS England, North Eastern Yorkshire. I think that's right. I can only say that because I'm reading it from your background.
Did I help you out slightly there?
Yeah.
I must admit I do need to update it, but I'll dive into that in a second. Am I all right to get cracking?
Get cracking, thank you.
Lovely. I shall share my screen. If anybody's got any problems with either hearing me or visuals, just let me know. I'm in an office today, and ironically, the technology never works quite as well when you're not in your usual place of work. So I'm more often working from home at the moment. You're absolutely right. I've been acting as the Deputy Director of Op Finance for Yorkshire and Humber over the last year to cover a secondment. As it happens, literally from last week, so I've still got some updating to do. I'm back in my South Yorkshire role as Donna came back into post. But at the end of August, I'll be moving across to the Midlands region to work for Chesterfield Royal Hospital as their Associate Director of Finance. So if I've got anybody on this call today that works either at Chesterfield or at Derbyshire or even in the Midlands, please do be kind to me when I move into your region. It'll all be quite new. So basically, welcome everybody to budgets. I'm going to share my screen when I can get my IT to cooperate. And it's thinking about it. And hopefully now you have a slide in front of you. Is that right?
Yeah, you're all good.
Lovely. Thank you very much. So yes, I think when I was asked to talk about understanding budgets and spreadsheets, I've taken this from a very basic somebody coming to a budget for the first time level. So apologies for that if you've got a little bit of experience, hopefully still be useful. And the first thing I was very conscious of is the sheer volume of jargon and finance-centric terminology that we use. Obviously compounded by the fact we're in the NHS, so we've got all of our NHS jargon on to layer on top of that. So I thought I'd just ponder some of the words and phrases that I use on a day-to-day basis, some of which are acronyms, some of which are not. Why it's coming up in bits, I don't know, but we shall add some of these all together, I think, and we'll get you to have a little look at these. And I wondered how much of these are familiar, if at all, to the non-finance world. So what I'd ask you to do is in the chat box, if there's something on the screen at the moment that you've never heard of before and you wouldn't know what it means, please just pop that in the chat box for me and let me know. And we will pick those up as a priority. I'm not going to do every single one of these. Oh, brilliant. Thank you very much. And we'll work through some of them and get a bit of an explanation for you so you know what on earth I'm talking about. Oh, brilliant. Lots of them. That's good. So we'll start with FOT then. FOT stands for forecast outturn. And we use it a lot throughout the year. Essentially, we're talking about how much do we think we are going to either spend or get an income, or what do we think our bottom line will be at the end of the year. So if you see on our report FOT, it means what we're forecasting that position to be at the end of the year. Every month that we do any kind of finance reports, there'll be a forecast outturn estimate on it. And it does move around, as you'd expect. So if we're early in the year, we're usually a little bit more optimistic. We've got, what is it, 9-10 months left of the financial year as we sit here now. So we know we've got time if things are going a little bit of a drift to recover that. And as we get towards the end of the year, obviously we try and narrow down that forecast outturn to be as accurate as possible. And we usually hope that by the time we get to month 9, we pretty much know where we're hoping to land at month 12. But once we get to month 11, quite often we're almost asked to hold that forecast. So if we report to our NHS England colleagues that we've got a forecast outturn of a particular number at month 11, then they'll expect that to be the number that lands at month 12 often. Not always, things still happen in month 12 that we can't predict, but that's your forecast outturn. I need my chat box open down to so I can see what the others were, but I did see ERF come up in that list. ERF's a joyous one for this and last year that you may be aware of from other parts of organisations. So ERF is the Elective Recovery Fund. So you may be aware that we've been doing a lot of work during the last couple of years on trying to recover elective activity following COVID. There is a fund nationally for this. We've got the funding this financial year, 23-24, and we had it last year. That elective recovery fund is a set amount nationally that is distributed to our local integrated care boards and the local systems. And the integrated care board then, on the basis of some estimates of activity that we're planning to deliver throughout the coming year, distribute that fund to its provider organisations on the basis of those plans. And what will happen this financial year is that all that elective recovery activity will be paid for on a variable basis. So there's another word I've not even put on the list, which means that what you do, you get paid for. So piecemeal, essential, like buying groceries, whatever you do, you pay for. So whilst we've given that money out up front to enable people to plan that activity and to build the infrastructure that's needed for it and have the staff, actually, if less activity is delivered, then that number will get tweaked to reflect the cost of that actual activity at the nationally held price. So ERF is your fund nationally. What else have we got in the list then that we want to focus on? I&E, income and expenditure. We like to shorten everything. Not necessarily complicated, but we like to shorten it either way. So yes, income and expenditure. If you're looking at a budget, quite often some people refer to it as your I&E or your I&E account, just so that we are covering both income and spend in the same place. Accruals. So this is a good one that always baffles people. So accruals are where, when you get to the end of a month and as finance folk want to report on what's happened in that month, we might know that we've spent some electricity, for example. Good example for current cost of living times. So we've spent some electric, but we haven't had the invoice yet. Now, it wouldn't be right to just ignore it and pretend we haven't got any costs for the current month, because we know we have physically used some electric in that month. So we have to put a cost manually into our systems, into our ledger, to reflect that cost in anticipation of getting an invoice. And those estimates, sometimes we can calculate them quite accurately. So we might have a meter that our estates folk can help us calculate exactly what we've used, and we can cost it up ourselves and be quite close. But we'll put in a manual adjustment that's called an accrual into the current month's position to reflect that cost that isn't yet showing properly. And it reverses out normally. So the next month, that manual accrual will drop out so that when the invoice comes in, it's in there on its own and you've not double counted. Sometimes you might need to do the same accrual for a couple of months if that invoice is really delayed. And similarly, you get accruals for income as well as expenditure. So similarly, you might not have quite accounted for some income via the raising of an invoice within your organisation, but you know you're due some income because you've done some activity. So we will manually reflect that income that you're due to receive at some point into the system until the system catches up. So it's us doing those manual corrections at month end to make the financial position reflect what we know to be happening. Now then, let me do one or two more and then I best move on. But I can always send out a list of all of these to everybody. What have we not done that we've got on the list that people are interested in? Bear with me. I&E run rate. So yes, this is quite commonly used at the moment. Actually, it's become quite an in phrase. Run rate describes the amount that you are spending on a regular basis. So if you, as an organisation, were to say spend, I don't know, say 50 million on staff in a year, and actually that's a really rubbish figure because I can't do the maths in my head now, 120 million for staff in a year, then in each month you would be spending your 10 million on staff. And that run rate is 10 million. So it's your monthly amount that you're spending on staff. And if your run rate is going up, it means every month you're spending more and more on that particular item. So your run rate is increasing, and that's obviously a bit worrying because all the costs are going up. And equally, you might have a run rate that's coming down. So you might be successful in reducing some of your costs through some new ways of working that are bringing that run rate down. So it's the monthly amount that you're spending on something, and we do occasionally use it to refer to income as well, but much less often. It's usually about expenditure. So there's quite a few others on that list. I'll quickly tell you what the acronyms stand for. So YTD is year to date. So that's if you've got a report that says YTD, it means the full year to the current date, or the most recent month end actually, probably not to today. Variance is normally a variance from your plan. PBR is a slightly out of date now, but still referenced. It's payment by results. It refers to a method of paying for what you use. So similar to how I was referring to how the ERF fund works. We've got PYE and FYE at the bottom. That's part year effect and full year effect. So that would be if you hire a member of staff halfway through the year. In the first year, you will only have half of their salary to account for. That's a part year effect. And then every year thereafter, you'll have a full year effect of their salary to account for. Efficiencies are savings you've made through doing things in a more efficient way. Depreciation is the cost of maintaining your assets. So operating from a building that's been bought doesn't mean you've got no costs. It's kind of the equivalent cost of maintaining that building that lands into the financial position. And a lot of organisations manage that centrally, so you may not see that on a budget report, but it's certainly worth asking about because bigger departments will have bigger depreciation costs. Recurrent, non-recurrent is about whether or not your cost is just for this year and it's a one-off, which would be non-recurrent, or whether it's a cost that will happen every single year. Again, like you've hired somebody, so their cost will be recurrent because you've hired them substantively, and therefore you need to find funding for it every year hereafter, including all the relevant information on that will come to the fore. And then finally, whole time equivalent in the middle, WTF, that's a payroll one. So somebody who's half time would be 0.5 whole time equivalent, and a full-time person would be 1 whole time equivalent. So there you go, a whole host of jargon to kick you off. I was never quite sure whether to do that first or last, but I thought we'll get that out of the way to start with, to just start touching on some of these phrases. I'm going to dive straight in now to kind of what is a budget, and just go back to the start, I guess. So your budget is your plan of what resources you require to deliver agreed level of output. Usually it's the first year of an agreed 3 to 5 year plan, and it's quite often determined and directly linked to the income that the trust earns. They're very much interdependent, and in some cases part of your income will be variable dependent on activity, as we've just talked about with elective activity, but a huge chunk of work done in a healthcare environment, secondary care, will be still on block contracts. So regardless of the amount of activity done in other areas, you'll still get a block. So what resources you therefore have available to deliver a service is very much interlinked with how much income you have available. Knowing that income and distributing it to ward level enables local staff to monitor a plan. So the budget is an ability it gives you the ability to improve your planning and monitoring against that plan and to keep on track. So a typical financial plan or budget, so we do use the words interchangeably. It would include a pay budget. So you'd have elements of what staff are you going to pay for, how much will they cost, and what's their whole time equivalent, how many are there. You'll have a non-pay budget, and this will cover anything that's not paid basically, other than a few exceptions. So the cost of training, any consumables, things like drugs, bandages, equipment for a ward that's low value, all of that will be in your non-pay budget. You will also have an income in your budget, so an income target, and that will be monitored as the year goes on. So what income are you earning? And as I said, some of that might be fixed and some of it will be variable. And there should be, when plans are set, an alignment, of course, between what we're planning to do as an organisation in activity, what workforce we need to do that, and how much that will cost. So we should be preparing all 3 of those plans, which are all submitted on big forms to NHS England at the planning stage. All of those should be prepared on the same base assumptions regarding what activity are we planning to deliver and what do we need to deliver that. So the what and the how. So just going into that in a little bit more detail then, budget holders, usually an organisation such as a hospital, will devolve its budgets towards, as I touched on. If you've been given a budget to look after, there's some responsibilities around that. Obviously, it means you're accountable for public funds. So this is taxpayers' money that we're spending on a day-to-day basis. And you need to manage that budget in line with your organisation's financial policies. So if you've not heard these words before, I highly recommend looking them up on your local organisation's intranet. You should be able to easily find, if it's difficult, then it's a problem, but you should be able to easily find your standing financial instructions. which is basically a guide to how the finances will work and what the rules are. Standing orders should be there as well, and the delegated authority document, which outlines how the organisation is delegating its budgets to its separate departments and what principles it's doing that with. Now, we'd expect each ward and department to have a designated budget holder. It just makes things that little bit easier to manage, and it gives everybody a manageable scale of budget as well to look after. So it's quite a helpful level to do it at. Sorry, my button's sticking, bear with me. Let's try that again. That's it. The idea is that you understand and are able to manage spend that's within your budget. And we talk quite often in finance circles about what's within control. So everything in your budget should to a certain degree be within your control or influence to manage. If it's not, then that's a conversation with your designated finance person to just have a chat through, how is this my budget if I've not got control over it, and should it sit somewhere slightly differently? How do we best manage this pot of money? A budget manager will work really closely with a member of the organisation's finance team. So you should have a designated finance manager, and they will help manage budgets in that they can help with understanding of things like accruals. They can help ensure your budgets really reflect what's going on and that we're not missing anything in that regard. And they can help with costing up alternative ways of doing things. It's really important to keep them up to date with what your thinking is on developments within your department, what current issues are, what the challenges the department's facing. Key ones at the moment is workforce, top of the list in terms of sticking within payroll budgets is really challenging when we've got a substantive batch of staff, but we also have a lot of vacancies within the NHS. So some of our staff has to come in via agency routes, which of course is more expensive and puts pressure on those budgets. And very quickly a budget can start to go off plan. So your spend can be not as planned. And it's important to just keep your finance manager really up to speed with what's happening there so that they can feed that up the chain within that finance circle and ensure that the finance department's fully au fait with the challenges that the organisation's facing. More broadly than that, identifying where there are opportunities to save money within your department, where there might be ways to do things differently, possibly looking at pay structures, looking at ways of doing things. Perhaps it might be working with procurement to do something that's a slightly different way of purchasing certain items that you need, and what other things are causing cost pressures other than the pay I've mentioned already. And you'll also need to be, as a budget holder, really involved in that budget setting process at the start of the year, in setting the plan for the next year. Because obviously, if you're responsible for monitoring against that, you need to have some involvement and influence over the plan that's set so that you thoroughly understand its basis and are able to really quickly know when it's going off plan, because actually, well, it was set on this basis and that's changed now. And obviously really involved with the finance team in terms of forecasting. So back to that FOT from earlier, what do we think it's going to look like by month 12? Are we going to actually recover some of these pressures and get things back on track? Or is it just something that's a bit more complicated and that's not going to be possible? So quite a bit of responsibility there. Don't let that put you off. Oh, sorry, I think I just missed one. Oh, sorry, I did. One final job, when budget reports come out, and you normally get them monthly from your finance team, there's something about having a look at that and checking it makes sense. Sometimes you might find a member of staff on your budget that's not a member of your staff. Mistakes happen, people get put in the wrong place on budgets, costs sometimes land on the wrong place. So it's just about that bit of validation to say, hang on, does that look right? Have we got everything on there I'd be expecting, and a bit of validation with your finance colleagues just to ensure that it's reflecting what you know to be your true position. So I've touched on some of this already. Setting budgets is that annual process. It should be both a top-down, bottom-up process. So using information from the wards to understand what's a sensible and realistic plan, but also recognising the limitations in terms of available funding and being pragmatic about, okay, so what is that compromise budget where we get that to be a realistic, ambitious but deliverable plan that we can aim to achieve. That process usually starts with the plan from the previous year and is incrementally adjusted in terms of what new investments can we afford to include, what extra funding do we need to put in for pressures that were beyond what we were expecting, have we changed our staffing, and what savings can we make from doing things more efficiently and reducing waste in our processes. The setting budgets bit, as I said, should triangulate with colleagues that are setting activity plans and workforce plans. So really getting involved with your HR colleague as well. Again, a budget manager, you would usually be assigned a HR lead from the HR department or workforce department, whatever that's termed in your organisation. And you'll need to sign off your budget. You'll be expected to sign up to the budget and take accountability and ownership of that plan for the year. So as you go through the year, you'll get a report every month from the finance colleagues, which will show all of your various types of spend, as we touched on earlier. So income, pay, non-pay, any other costs that are a bit unusual. So you might have depreciation in that section. Organisations have to pay a capital charge on their buildings, and that's 3.5%. That's again quite often managed centrally, but it could be devolved, and you might see that on your budget. And you might see some interest charges if you've got some leases running through your budget as well. So leases are dealt with in quite an odd way as from last year. And again, finance colleagues can help with that. That's quite technical. But again, it's just about the way in which a cost of a lease is presented that you might just need to understand if you have leases in your area. Plans, actuals and variances will all be in your monthly report, and the year-to-date position will be shown as well as the forecast outturn that you've worked with your finance colleagues and should look familiar to you. So there's an example of a really basic budget report here. I highly suspect what you will get will have a few more lines underneath each main category. And you may even have an in-month set of columns as well, so you can see how just the most recent month has gone. But at a very high level, you can see that on this particular budget report, there was a plan for income of 114 million. It's quite a large report. And the income that's actually come in to date was 112 million. So that's a £2.161 million variance. And since that's income, that's not good news. That's income less than we expected. So your reds are not great in that line. Pay costs, 44 million planned, 45.8 actuals. So that means you're overspending on your pay. And non-pay is a slight underspend. So you can see there's a 417,000, looking at the column headings to know what units you're in variance on non-pay, which gives for that particular period a 3.4 million deficit. Essentially, it's a problem against plan. Now, in this particular example, that's the full year position that's shown first. So in the middle of the screen, you'll see slightly smaller numbers in the three columns to the right. That's the year to date. Each organisation has budget reports that are laid out slightly differently, so check your headings. I would comment that this one hasn't got great headings, so you should be able to tell really clearly if that's a year to date plan or a forecast outturn plan. So if you're unsure and if anything's unclear, check with your finance reps. And of course, that will help you understand where you're at. These slides I'm hoping that you will get access to. Essentially what I've done is added into it the comments that I've come up with, but I'm very conscious of time today. I thought we might have an opportunity to just have a bit of a think about what those were showing separately, but I thought we'd dive straight through it today since we're a bit limited. This is just an example of tables and graphs that you may see. You may see variance on a theme. Your finance department can provide all sorts of information. This one is quite small, apologies, but it's basically showing you that that information is available on a month-by-month basis, and your finance teams can give you graphs that show what's been spent on pay each month going through the year, that run rate. And obviously, if you put that on a graph and the lines going upwards, you can see really clearly that your pay costs are increasing. So there are different ways that your finance colleagues can help you visualize what's happening. And we very much seek to provide what's useful for the individual. Some people like tables, some like graphs. It depends on what's your preferable way of taking in information. Forecasting's a tricky job. It's essentially about using what you know and history to try and guess the future direction of travel. By doing a forecast right from the beginning of the year, so we've just done month 2 reporting and everybody's already given their month 12 forecast, it provides us a forward look of what we think we're going to spend and allows us to start to manage anything that's drifting off plan. It helps identify risks, helps with decision making and aids budget setting for the next year. Budget managers in that role are helping provide their finance teams with predicted changes in their services. If you know something's coming down the road in your particular service that may fundamentally have an impact on how you operate, let the finance team know, have a bit of a chat about what that means for the service, what that might look like, is there additional income, is there additional cost, and that will enable them to accurately predict your forecast for the end of the year. It also helps if you can keep them up to date with recruitment plans and any thoughts on what you're doing when people are leaving and what cover requirements you're putting in place. Efficiency programs are quite high on the agenda when it comes to talking about finance and budget setting. Got quite a few examples on this slide. I'm going to bring them all up at once. Essentially, efficiency is about looking for ways to do things better, not in a way that will detrimentally impact patient care at all, but in a way that absolutely maximises the limited resources we have in the NHS to provide the best possible care in the most efficient and effective way. Quite often we find that when we really think about delivering effectively, the costs go down naturally. So the two tend to align. Because we're in such a challenging financial position in the NHS at the moment, there's more talk about how best we can deliver some of our efficiency programs. And the efficiency program is, again, a plan of how we can take some costs out of the system while still maintaining service and just doing things better and removing the waste. So we'll all know that quite often we do things in a way that's not effective. We quite often duplicate. So it's finding those instances and removing them. There's some examples here. A big one is about making sure we use our procurement colleagues' knowledge to get the best deals for us when it comes to procurement. So, for example, switching to different drugs or consumables can really make a large impact on the money the trust has available to it. Reducing reliance on high-cost temporary staffing can then enable you to use that money in a different way. So sometimes it's about saving in one area to invest in others. So it's something to think about as a budget manager. It definitely will be on the agenda. So please have a think about, if you're managing budgets, how you might remove waste from those budgets. That's in all of the areas: pay costs, consumables. Is there an opportunity to increase your income? As I said, some of it's blocked, but is all of it? Are there opportunities available to you in your particular area? And how could you improve your productivity? So are there ways you can maximise ways of working? Theatre utilisation is a good example here. A lot of trusts do a lot of work on how to maximise the use of their theatre space in the best possible way. That was very much a whistle-top tour as what you can expect managing budgets. Has anybody got any questions? And is this where I get silence? I love this bit.
Generally.
Everybody's just, it's that time of day. I'm sorry, I've caught you all mid-afternoon. You're probably worn out after a very busy day. So apologies for throwing a lot at you.
You're lucky I got to the final session.
Good luck.
Oh, we got a hand up.
Love. Oh, thank you.
Hi, Louise, can you hear me?
I can just about. It's not a great line, but I can.
Sorry, can you hear me now?
Oh, that's a little bit better. Yes, thank you.
Yeah. So, I mean, I've heard of CRES,
Yes.
efficiency savings and all. Which aspect of the forecasting or the budget decides how much CRES we should achieve by the end of the year?
Oh, that's a really interesting question. So this will depend on the principles that your organisation's adopted. So at the beginning of the year in that planning process, an organisation usually works out quite quickly the scale of efficiencies in terms of percentage saving needed for the organisation based on what income it's going to expect as a whole and the cost that it's seeing running into the next year. And it will look at that and say, okay, I think we're going to need 3%, say, overall. How it then distributes that challenge across the organisation is very much down to the organisation and its board in terms of where opportunities sit. Some organisations use something called service line reporting, which is a different way of presenting the same information as budgets, but it pulls in some of those other costs around estates costs and enables you to look at budgets in a more profitability way to see which areas are making profits, which areas are making losses, is there opportunities in different areas. And they might also be informed by some of the work that Model Hospital does in terms of where there are opportunities. So they might decide, actually, we've got a service over here that did really well on efficiencies last year. They're really struggling to go any further than that. They've done a huge amount of transformation. We don't think we can push them for the full 3% that we need overall, but we've got this other department over here that we're going to challenge to hit 4%. And that might be how the board works. And there will be various different ways of doing that, and everybody does it differently. So it will be very, very organisationally specific, I'm afraid. It's one to ask your finance team, definitely, in terms of how that's been decided in your organisation in terms of the challenge that you've got on your budgets.
Thank you.
No worries. Anybody else?
We did have another hand up. Oh, okay, something different. Yeah.
Lovely.
Hi, Louise.
Hiya.
So a quick question for me. So the example you shared, the budget, the report, I think I saw on there that the pay started in red. Is that correct, or it's just an example? So is it possible for a budget to start in deficit?
Oh, I see what you mean. That's a really good question. It can throw people. So depending on which organisation you're in, and am I still sharing? Let me share. I'll go back.
Yeah, you
are. Will depend on how they present this. So in this particular example, the organisation treats income as a debit and costs as a income as a credit and cost as a debit. And in our world, that means that income is a positive and costs are a negative. And if you look down that first column, the plan column, it means that as a single column, the income of 114 million outstrips the costs by 44.9 million. So the negatives for pay aren't a deficit necessarily. It's not saying it's what it's saying is cost. So it's got to have a different signage for income versus cost. And some organisations have income as with brackets, and some has income not with brackets. So you have to kind of work out which way round are we, and then know whether you've got ups or downs. So it can be a bit confusing. But yeah, does that help?
Yeah, it does. Thank
Lovely.
you.
Good.
Yeah,
no worries.
Great. Any other questions?
No, if anybody needs to know anything else, that I'm happy to take questions, or you can email me. It's not a problem at all. Thank you very much for your time today.
Great, thank you, Louise, for coming along. And so for our final session of the day, it's back to me again. I'm got the dubious task of talking about business cases. Now, unlike procurement, this is one of the areas I can do. So we're going to talk about business cases, and generally with these audiences, we have quite a mixed bag of people's experience with business cases. So what are generally people's experience with business cases? Do you have very little knowledge, some knowledge, quite a lot of knowledge, and you want to know some tips? So just before I start, so I can pitch it, normally have a bit longer in these sessions, but we've tried to cram lots of sessions in today, and so it's a bit more it's a tighter schedule than I was expecting. So some people have got some knowledge, okay. Okay, some knowledge but lacking success. Okay, so we got the whole gamut of very limited, a little knowledge, no knowledge, some knowledge. Okay, fine. Okay, so what I'm going to talk about is so business cases. Business cases are essentially vary in terms of your organization. So the process varies, the paperwork will vary. What I'm going to be talking about today is the official business case process. It's called the Better Business Cases 5-case model. It is what it's been devised, has been around for about 20 years now. It's what the public sector are encouraged to use as their model for business cases across the whole of government. And you know, what we're going to do is we're going to cover it very superficially. I'm going to go into it in a little bit of detail, but quite superficially, and we're going to go through some areas that are focused for the NHS purposes, rather than the ins and outs of the actual Better Business Case model. Better Business Cases runs courses. There's a foundation and a practitioner level, but unless all you're doing most days of the week are doing high level business cases, I wouldn't worry too much about the actual qualification. It's the principles that apply that are the most important. So okay. So as we're short time, I'm not going to ask lots of questions because it does. I want to get. I don't want to overrun too long. So a business case is basically, there's two purposes of business case. One is an ask. One is an ask for resource. Normally, you're putting a business case because you want resource to buy something or develop a service or something along those lines. The other is purpose of business case is to look at the process by which a decision came. So why did you choose to buy that particular product? What was the process behind it? So that was part of the purpose of business case. Okay. So there's two purposes: the ask, but also a decision-making framework. The first thing you've got to do when you're trying to think of the concept of developing a business case or writing a business case is understand the process that you are going to have to go through. There are very normally a number of hoops you've got to go through, and you've got to have an idea of the ballpark figure you're looking at in terms of cost, because that will determine how far up the chain you need to go, who needs to authorize it. And the same way as procurement that we talked about earlier, there are rules and regulations based around the cost of the value of the resource that you're acquiring, whether it be developing a new service or buying a bit of equipment. It's also important to know who you're going to pitch it to. Is an internal business case for your own, within your own organization? Is an external business case to develop a new service that you want commissioned? Is it something that needs to go through an education budget? Are you doing a pitch for a national pool of money? Okay, so there's different purposes and different processes involved, and it's important to understand what you're doing. The next bit, what needs to be in a business case? And essentially it's all pronouns: the who, what, where, when, why, how much. All needs to be in there, but it needs to be in a structured way so it's clearly understandable to everybody. So what we're going to use is the 5-case model. And I said, you'll get the slides to this, but there are the strategic case, the economic case, the commercial case, the financial case, and the management case. What I would generally say is the financial case and the commercial case, you need specialist input. And so you need to get your procurement, your HR, and your finance teams involved to give you the backing and the kind of the data that underpins those aspects. I'll touch on them briefly to give you an idea of what kind of things to consider, but those are kind of specialist areas. what we're going to focus on mostly is the strategic case, the economic case, and a little bit on the management case, because that's the bit that the non-specialists kind of tend to have to write about. So the key components of a business case: it has to be desirable, it has to be something you want, you need, has to be viable. It's going to have to work, and you have to be, you know, within the remits of what's achievable. Now, I can write a business case for a whole new hospital, but that's not within my, you know, not with any of our purviews to get quite to click your fingers and get it. That is a national process, okay? And what you're looking for there is a much bigger problem, a much bigger solution. Okay, so it's got to be achievable, it's got to be viable, it's got to be desirable. I mean, I can build a whole new hospital on my site, but that's not achievable because I have to knock down everything. So again, it's got to be, you know, realistic. And then the next question is, what are the drivers of business case? What is the thing that you need to that underpins a business case? Now, traditionally, in times past, business cases were written a lot to a lot of the time they weren't to solve a problem, but they were out to generate income, because we were on a kind of tariff-based system, and a lot of business cases were designed to generate income for an organization. That's kind of reduced in popularity. It's reduced because, you know, money is even tighter than it was previously. And so the main drivers of a business case are to solve a problem or to improve quality. The biggest issue that I've seen when I've looked at business cases and reviewed business cases for other people is that often business cases are written with a solution in mind. And it's clear that business cases are a solution in mind, and they've only thought about that one solution. It's been very much very narrow-minded, I won't mean narrow-minded, but very fixed position on this is the solution that I want. And without having a kind of slightly wider purview and wider perspective on things. And so the best way, and if you get nothing away from this talk other than that, if you write a business case, you needed to solve a problem. Okay, that is you have to have a problem, you have to sell the problem to have a business case to be the solution for. You can also do it to improve quality, but you have to have a really strong argument for that. And it ultimately goes back to the value equation that we talked about this morning. You know, clinical outcomes, experience, safety, they have to be in there. You have to have an improvement in quality, and it's going to be versus the costs that you incur. Okay. So that has to be, you know, front and center of your business case. That's got to be the thing that's pushing it forward, that the improvement in quality. So what needs to be in a business case? Well, this is the kind of overview, and we'll come back to this in a minute. I'm going to skip through the kind of processes. So if you are doing a massive, really big business case, it can be broken up into stages, which is this diagram. This is the official process. You can get a strategic outline case, which is where your case for change is established, and you kind of identify your ideal ways forward. Then you do an appraisal of your shortlist, and you identify which one you want to go with. And then it's a decision to proceed with. It's the open journal of the EU, which is what that OJEU means, and that's just the tender contract portal that used to be used when we were part of the EU. Now it's just a contract finder portal. And so you go through the procurement process. You do the procurement process, and then you decide to contract. In some cases, you go straight to the full business case. Some places you want to go through step by step, and it depends on the size and the value of the business case. But for most people, the business cases are much more straightforward. They're a bit smaller, but the forms are a bit easier to manage. But they form the same principles. In that, the first bit is a strategic context, a strategic case. And that's all about the context. How does it fit in with the the organization's aims and ambitions. So you have your annual plan, you have your trust values. You've got to work out, or you've got to show that your business case fits and aligns to those organizational aims and ambitions. Okay, it's got to fit within the trust strategy. Okay, because otherwise the organization will be less inclined to put forward your business case. That's the first step. The next step is to really have a good case for change. And the more evidence you have to show that there's a problem, the better, the stronger your business case is going to be. So this is where you've got to do your pitch of what's driving your business case. What's the problem? Is it because of benchmarking data? Is it something, some recommendations from the Care Quality Commission? Is it the getting it right first time GERFT recommendation? Is it from data from the model hospital? Is it from NICE or Royal College recommendations? Is it from your mortality reviews or root cause analyses? Look at what your case for change is, because that's really important to give weight to your business case. Because the business case committee, whoever's reviewing a business case, may have 20 business cases and only a certain amount of funds to go for. So you've got to show why your business case is so important that needs to be done this time and not in the future. Because there may be 10, 15 Royal Colleges with multiple recommendations every year, each varying costs implications. Why does your one need to be done now and not in the future? So an example, again, as I'm an anaesthetist, so unfortunately a lot of these will be surgical anaesthetic examples. Desflurane is a anaesthetic gas. It's really bad for the environment, and there is a NHS England target to reduce the usage to when this diagram was written by 2022, it was to reduce it down to below 10%. By 2023, it was to below 5%. And this is taken from Model Hospital. I used this diagram to show that we needed more pumps or kits to use as alternatives to desflurane. So we were quite bad. We are now desflurane free. That's not purely because of the pumps and stuff, but this is an ammunition that showed that we were really bad in terms of our desflurane usage, and we needed some other equipment to encourage the shift away from desflurane. Now we had a whole program behavioural change as well to go alongside it, but we use this to get TCI pumps to help us shift to total intravenous anaesthesia. Okay, so use the data to make your case for change. If you've got targets, if there is anything that needs to be there. We also looked at ICB environmental sustainability pots of money, so look for where the pots of money might be. And I'll talk about top tips for looking for pots of money in a bit. This is another thing, again, for Model Hospital. This is to do with the 2-day rate of length of stay for emergency appendectomies. So there is a drive to reduce our length of stay to less than 2 days for emergency appendectomy. We are very well. The black line is my trust. Again, this is a few months, well, a couple of years ago now. Very low rates. And if you look at the data, so you can use that data and you can analyze using your Flix data. You can go to the next level and go, actually, the reason for that 2-day length of, well, a really poor 2-day length of stay for appendectomies is because most patients don't get an operation until day 2 because our emergency capacity is limited. So we can use this data to put in a business case to increase our emergency capacity in the evenings and the weekends. Theatre capacity to perform these operations. So we can use that because it's not that we have a high rate of complications. It's just that patients wait longer for their operations. Some of them then have more advanced disease, which then means that you have an issue. So we can patient satisfaction. Patients aren't starved for multiple days at a time, not only to have the operation delayed. Patient clinical outcomes, they're reducing the length of stay, reduction in complications. Patient safety, we actually, if we do more operating during the day, there's less pressure to do operating overnight, which improves patient safety. Okay, so all three domains of quality get approved, and you can then look at the cost implications of that. Okay, so again, use the data. The next bit of the strategic case is to kind of look at all the things that make up your current system. Okay, so by that I mean, what are your existing arrangements? You know, for say for my theatre example, we have two adult theatres that run from 8 till 6, one theatre that runs 24/7, and one paediatric theatre that operates intermittently. Okay, so you look at your existing arrangements, existing staffing. What are your business needs, current and future? So your current needs are, we have X number of emergency capacity, 8 emergency cases every year. What are our future needs? Well, if I was writing this last year, I'd say we're about to do a massive reconfiguration that will bring all emergency general surgery onto one site. It's currently on 2 sites, which will massively increase our surgical emergency theatre requirements and case mix. So we need more capacity. Okay. So that's our current and future needs. Okay. What's going to restrain you? Well, our theatre capacity in terms of number of theatres. I'd ideally have a whole new theatre, but that's going to have a knock-on effect to elective care. So that's going to constrain us. So the most common reason for constraints in business cases, estates, is your physical estate facilities that are going to limit you. So theatre capacity, clinic capacity, all that kind of stuff will limit how much you can do. Dependencies are again related to is if one business case is dependent on another. So you might have there was a business case that I came across recently for radiographers, so to perform imaging. Now the business case is for extra radiographers and a consultant radiologist, but the driver for the business case was that they were building a whole new orthopedic day case centre. They needed X-ray facilities. So the success of the kind of day case unit business case was dependent on this radiographer business case working out. Okay, so one is dependent on the other. It's always useful to have one dependent on the other, because the smaller business case is almost, if the business case is second business case is a big one that's a whole organization wide one, then the small business case is more likely to be improved. Scope is about what's going to, what are you looking at? We're looking at realistically, we're looking at extra capacity. We're not looking at building new theatres. We're not looking at building new buildings, because that's beyond the scope of what is realistic. Okay, so that's going to be the scope of what we can do. You've got to show benefit, obviously. And what are the risks? The risks are for this one is if we staff an extra longer theatres, okay, we may not have enough staffing to cover other things. Okay. So the risks, so benefits are things that are good things that are going to happen. Risks are things that might happen. And there's something called disbenefits, which are bad things that are going to happen, okay, as a result. So an example would be, I once talked through a business case for a radiologist who, as part of their breast screening service, rather than mammograms, they wanted to do another form of test which involved some sort of injection, which had a higher accuracy rate, faster results, more consistent. Great idea. The problem is that it then reduced the number of patients that could be seen per session. So the disbenefit of that process would be that you wouldn't be able to see as many patients. So it builds up your waiting lists potentially, unless you put something to mitigate that, which would be to increase the number of sessions you deliver. But so benefits, good things, disbenefits, bad things, risks, problems which may happen. Okay, so that's a strategic case. 4 minutes. Not going to get through this in 4 minutes. You can use demand and capacity modeling to give you an idea of your kind of your needs in the future. So this is an example I took from some radiology kind of imaging business case. So they suggested that every year, and it was a bigger table. Every year there was a 5% increase in the number of imaging tests that they are required to perform. Okay, the same could be by pathology. They could be by all kinds of things. Okay, so your demand is increasing. Okay, so there you go. Actually, so even if we did on a low scale, we went for a minimum of 2% increase. We can build that into our demand and capacity modeling, and then you can go, actually, okay, so what does that actually mean? That would mean you'd need this many extra lists, this many patients would be seen on the list, and this is how many lists would be seen per year. Okay, based on a 48-year. Now, back in the day when, and it depends on the actual financial modeling that goes behind it and the payment system at the time. When this was written and we were on the tariff system, they forecasted an additional income that these extra lists would generate, which would, for the most part, probably cover the cost of the new staff. And that's how they justified that business case. So you've got your strategic context. You've kind of put forward why you need it to change, what your problem is. The next thing is to come up with a long list. Now, the long list is anything you can think of that could potentially solve the solution. And you've got to think a little bit outside the box. And you've got to think of somebody who doesn't know your service as well as you know your service. And come up with ideas that and come up with kind of potential solutions that you know may not work, but somebody might put forward. Because that's how the long list works. You kind of go, okay, these are all the potential solutions that I can come up with, and then you come up with your assessment criteria. Now, there's lots of ways doing assessment criteria. One way would be to have your desirable, essential and desirable criteria. You can have your critical success factors. You can weight them if some things are more important than others. You just need to have some sort of criteria by which you're assessing these options. And then you kind of shortlist them. And you really need to come down to about 3 minimum different options that you're going to look at. And it must include a do nothing or what is the minimum thing you can do option to solve your problem. And what the consequences of that. And then you do an economic appraisal, which is basically looking at the qualitative effects, benefits, the quality improvement benefits of each option. How do they stand in relation? One may be the most expensive and have a vast improvement. Number 2 may be much cheaper but have a significant improvement in costs and quality outcomes. The other one might be the cheapest but have actually no benefit, qualitative benefits. Okay, so you can look at your benefits as a qualitative assessment. And then you get a ballpark cost appraisal of how much each option may cost. Okay, to give you an idea of how the cost would be. So again, that helps you decide what's within your scope and what's not within your scope. A way of doing an options appraisal, if you can't think of a way, you had lots of different options, this is one way of doing it. Okay, so the general term I use or case study I use for this is HS2, the high-speed rail links. Okay, so the business case would be for improving railway capacity across England. That would be the business case. That'll be the problem you're trying to solve, improving business case, railway capacity. Okay, so the scope is the minimum option would be to improve the capacity between London and Birmingham. The maximum would be between London, Birmingham, the north west so up to Liverpool. And the maximum would be to do all of that plus do a branch up to Sheffield, Leeds. Okay, so that'd be your maximum. How you do it, the minimum would be to refurbish the existing track. The maximum would be to build a whole new track, and the intermediate would be a mixture of both. Some refurbishments, but some new track. Okay. Service delivery, who's going to do it? Well, you can do it. In this case, it'll be a local contractor, national contractor, international contractor. In the healthcare setting, it could be who's going to be there. Is it going to be a consultant led? Is it going to be nurses? Is it going to be MDT with multiple consultants, AHPs, physios, OTs? You know, depending on what the service delivery is, who's going to be delivering that service? Okay. When is all about how it's going to be rolled out. Are you going to do a pilot? Are you going to do so in the HS2 example, it'd be the minimum would be to do London, Birmingham first, then to do Birmingham, Liverpool, and then finally to do Birmingham, Leeds. You know, do it staged. Maximum would be to do it all at the same time, and intermediate would be to do, you know, some concurrently and some separately. And in funding, you could have, for the HS2 example, it would be all coming out the public purse, or all being covered from private funding. Okay, and that will be from nominally from increasing ticket prices. Intermediate would be a mixture of the two. Again, what you then do once you've filled it all in and come up with your appraisal is you kind of, with justification, you kind of highlight the ones that are no non-starters in red because they're non-starters, and you explain why they're non-starters. For example, what London to Birmingham on its own would be a non-starter because it doesn't solve the problem. That's not where the data shows the issues are. It's further afield than that. So anything that's non-starter would be red. Anything that's possible but not preferred would be yellow, and then green would be your preferred options. And you'd have to explain and your rationale for each one. Okay, so that's how you'd kind of break it down in different ways. So we've covered strategic case. Is it needed? Why do we need to change? The risks and benefits must include a quality case. We've covered a little bit about, is it value for money? That's your qualitative assessment showing improvement quality versus cost. What options have been considered and which option has been chosen and why? I briefly talked about procurement processes earlier, about whole life costs, making sure you understand that concept when you're comparing different suppliers. You also have to look at contracts in terms of whether you have an existing contract or whether you need a new contract. Personnel issue requirements is all about working time equivalents. So for a consultant, generally speaking, when you're building in the contingency, you do it for a 42-week year. So if you want a clinic every week for a whole year, you need more than one working time equivalent of a consultant. Nurses, and agenda for change staff, are on a 37.5 week, 37-hour week working week. So again, depending on what your